Okay, it's time to start the webinar. So welcome. We're glad that you were able to join us. Before we hear the speakers, I'd like to go over a couple of the GoToMeeting and GoToWebinar features. Okay, if you see a cow looking at you, then you know that everything is going well. Now, on the right side of your panel, on the right side of your screen will be a panel that looks sort of like the panel that's shown on my screen here. You'll see I've circled the telephone numbers in the middle. Your numbers will be distinct for you, so that's why I've covered up the numbers that were on there originally. So make sure you dial the toll-free number, dial the access code with the pound sign, and then the audio pin with the pound sign, and then you should be ready. Below that, you'll see the orange arrow that goes to the chat box. This is where you can type in any questions or comments you have, and you can either send it to the organizer, which is me, or you can send it to the entire audience. So I think that that's it as far as the information goes. Oh, if you don't see the panel at all, look in the upper right-hand corner of your screen and look for an orange box with a right-facing arrow in it. Click on that arrow and it will either open up the panel or close it. And you might want to close it if it's interfering with your viewing of the slides. Okay, now at this time I am going to turn the webinar over to Dr. Laura McNicholas, who is our first presenter. She is the Associate Professor of Psychiatry at the University of Pennsylvania and at the Philadelphia VA Medical Center. Okay, Dr. McNicholas. Dr. McNicholas. Dr. McNicholas, can you hear me?
I can hear you.
Okay, so I think we're ready for you. Do you have the notation on your screen to show your screen?
I just took it off.
Okay, so we're all set.
Are my slides
now. Thanks.
Are my slides up?
Yes. Well, I see the blank slide.
I see a blank slide too, and I don't know why it's blank. Okay.
So, okay, I'm going to mute myself now. Thank you.
Okay. Good afternoon, everyone. This is Laura McNicholas, and they asked me to do kind of a 101 for methadone, and particularly with reference to the issues that we face when treating pregnant ladies with methadone. So what I'm going to start with is how it works. What does it do? Why do we use it? And that's actually a huge question, and one of the questions that I'm not going to answer in the first slide. So let's just look at why methadone works. For instance, what are the goals of pharmacotherapy specifically for the treatment of opiate dependence? And the first thing is to prevent or reduce withdrawal symptoms. If a patient is withdrawing, they're going to go out and use. So we need to get them and keep them out of withdrawal. The second is to prevent and reduce drug craving, because if they feel like they want to use, they know exactly where to go find it. They already did that. Prevention of relapse to use of addictive drugs. So basically we want them to be stable on just what we give them. Those are the goals. And not to be high and not to be craving, but to be able to function. So we want restoration to or toward normalcy of any physiologic functions disrupted by the drug abuse. Okay. And one of these is specific for women, because when a woman is addicted to opiates, you get severe disruption of the menstrual cycle. I have literally had women come in and I say, you need to be on birth control, and they say, oh no, I can't get pregnant. I've been having sex for 4 years and haven't gotten pregnant. Well, that doesn't mean you can't get pregnant. What it means is your cycle is so severely disrupted that you don't know when you're ovulating and when you're not. So you were just lucky. But the fact that the opiates so severely disrupts the menstrual cycle, a lot of times women don't know they're pregnant until they're into their 4th or 5th or sometimes 6th month. And so this is one reason why addicted ladies sometimes come into treatment later in pregnancy than we would like, because they've not gotten pregnant in 2 years, so why should they be pregnant now? And then all of a sudden it's like, well, yeah, you're 5 months along. Oh, okay, not good. The issue with methadone for people who are not pregnant, women who are not pregnant, is that it normalizes the menstrual cycle. Well, I was talking with a group of people a few months ago, and one of the questions I asked was, how many of you have pregnant women in your program? And a huge number of hands went up. And my next question was, did they come in pregnant or did they get pregnant afterwards? And most of the answers were afterwards, because methadone normalizes the menstrual cycle. These ladies don't realize that unless you educate them, and so they don't take precautions. So you really need to educate your patients about appropriate means to prevent unwanted conception. A lot of these ladies know once they start stabilizing that they're not ready to be moms yet. And so let them make the choice as to when they get pregnant. But they need the education that they're much more likely to get pregnant on methadone than they were on heroin or oxycodone or whatever it is that they're using. So I know that sounds like a really long thing, but I can't emphasize how important it is that when you start a lady on methadone, you need to A, do a pregnancy test, and B, do the education about contraception. So why do we use methadone? And that comes to the profile for a potential psychotherapeutic agent. We want it to be oral. Our patients have enough experience in snorting, injecting, and other things, so we want it to be an oral administration or something that goes in the mouth, or else a once-monthly injection or something like that. We need a long biological half-life. And the reason for this is patients get used to medicating frequently, and we need to break that cycle. It's part of the treatment for addiction to break that cycle of medicating every 3, 4, 6 hours, whatever it is your patient's used to. You want minimal side effects during chronic administration. If patients are having side effects, they're not going to stay on the medication. You want it safe. You don't want any toxic or serious adverse effects, and you want it safe in the long run because a lot of patients are going to be on it for a long period of time. And it needs to work for a substantial percentage of people with the disorder. If it only works for 3%, then that's probably not the right thing. Why do we need drugs? Why do we need to treat opiate dependence with an agonist? The reason for this is, first of all, for the opiates, we are lucky to have agonists. And why do agonists work so well is that the patient has become tolerant and physiologically dependent. What this slide demonstrates is Tom Pate's take on where most of us live, which is the normal range, and where our patients frequently live, which is loaded, high, whatever version they use for what most physicians call euphoria, or sick, or withdrawal. So what you see when a patient is taking a short-acting drug, such as heroin, works the same way with oxycodone, by the way, unless they're taking the 12-hour version the way that they're supposed to with 12 hours, is you get an immediate response. The blue line, straight up into feeling really good. And then you see it decline over time. Now, one of the things that I want you to remember is what some of those things were. The middle is the normal zone. So really, if you're looking at this for 24 hours, they spend about 2 to 3 hours in that normal zone. The first hour, they're feeling really good or euphoric or high or however they want to put it. Then they come down into what you and I would consider pretty normal as far as their feelings go, and then they start getting sick. Well, we all know that our patients are not going to tolerate that, so they're going to use again. long about the time that it crosses that bottom black line. What you want with methadone, okay, before I get to that, one of the things that we've noticed in opiate-dependent patients is where that purple box is kind of where they would prefer to be. They don't want to be so intoxicated that they can't function. But they don't understand what most people consider normal. And Tom has dubbed this abnormal normality. And it's right on the edge of normal functioning and being intoxicated. What they definitely don't want is to be subjective or objectively, certainly not objectively in withdrawal. So what you want with methadone or another agonist is to maintain the patient in the normal range. You don't want them sick before they get their dose in the morning, and you don't want them sick 24 hours later when they come back into the clinic. You also don't want them intoxicated halfway through the day or 3 hours into the day or anything else. You want them right in the range of normal, and that's what we would call the effective range of the drug and of the medication. And so that the patient is not intoxicated and they're not in withdrawal, which a couple slides ago is exactly what we said we wanted. And we actually have medication that can do that. What's the impact of maintenance treatment? And I know a lot of people say all you're doing is substituting one drug for another. Actually, you're not. You need to be providing treatment so that the patients can accomplish things such as reduction in death rates, reduction in intravenous drug use, which also means reduction in HIV and hepatitis C. Reduction of crime. It's one of the first things that we see with our patients is they stop committing petty crimes. Reduction in the rate of HIV seroconversion, I already talked about that. Reduction in relapse to either intravenous drug use, snorting, or any other drug use. And then improved employment, health, and social functioning. And most people forget this latter one. They go, okay, so the person's not using. But that's not the whole point. The whole point is not only should the patient not be using illicit medications, they need to be functioning better. They need to be working, going to school, making their doctor's appointments, watching their diets if they've got diabetes, etc., and being able to socially function more appropriately. I'll never forget the time that I had a patient come in and say that for the first time in 10 years he was taking his wife out for dinner on their anniversary because he was actually straight enough to be able to do it and to be able to socially function. And we sometimes forget how important that social functioning can be. So what are some of the issues in maintenance? Well, the big one is how much, and the second big one is for how long. And I always get this. I only treat a patient for 3 months. I only treat a patient for 3 years. I only treat a patient for 30 years. There really isn't how much is enough. We don't have preset things. And how long should opiate agonist treatment last? Long enough. One of the things that I frequently say to patients, to people, physicians, clinicians, counselors, everybody else, is you treat the patient as long as they are benefiting from the treatment and wish to continue. There should be no preset, I only treat patients for X amount of time. Or after a year, I try and get them off. We know it doesn't work. So for as long as the patient desires and benefits from continued treatment is how long the patient should be in treatment. And if the patient wants to taper off of methadone, absolutely. Work with them to taper them off. But don't insert your belief that this is how long it should be. Induction is the big bugaboo. Patients are almost 7 times more likely to die during induction than even if they're not in treatment. And this is, I'm sorry, but it's for people who don't know how to do induction. And unfortunately, we have people out there who are using methadone and do not know how to do induction. 42% of drug-related deaths occurred during the first week of opiate maintenance treatment, and this was an Australian study. And 10 opiate maintenance treatment deaths are reported, and all 10 have been in treatment for less than 7 days in the Drummer paper, again out of Australia. The issue here is not that we can't do it safely, but a lot of times the patients are going, I need more, I need more, I need more. I cannot tell you how many times I've had a patient come in for an intake and sit in my office and say, can I start on 80? And the answer is no, because 80 is not safe for anybody unless they're already on 80 and they're transferring from another program. If your patient is non-tolerant, they've just been chipping and using here and there, and they really don't have a lot of tolerance, start on 5 to 10 milligrams. They're probably going to say that they need more, but part of that is the addictive disease speaking that if some is good, more is better, so I need more. If you don't know how much tolerance there is, I usually start with about 20. Had one of my fellows come in yesterday and say, well, he says that he's down to like 1 or 2 bags a day, so I was going to start him on 30. I said I'd start him on 20. If the patient says they're using 1 or 2 bags a day, my guess is they're using 1. Because usually our patients overestimate how much they're using when they talk to us initially because they're afraid we're not going to take it seriously. As a result, I frequently ramp down what I think the person is using. So for unknown tolerance, 20 milligrams a day is a good starting dose. You can always go up. If the patient overdoses, you have problems. And if they have known tolerance, I will start on about 30. If I've known this patient and they come in and out of the clinic, a couple times a year or something like that, and I know what they pretty much do, then I'll go ahead and start them on 30. I do not routinely start anyone on 40 milligrams anymore. I just don't do it. The only time I would do that is if they're in another program and they're coming in on 40 milligrams or more. Other than that, it's 30 milligrams or less for my initial dose. What you want to do with early induction is to reach a therapeutic window where we have that purple line going across, keeping them not intoxicated, not sick. And you want to reach that as rapidly as possible, but in a safe fashion. And so you want to increase the dose until the patient is comfortable during the peak methadone period blood level. And that's 3 to 5 hours after the dose. Then you need to slow down your dose increases. With pregnant ladies, this is a little bit different because you don't want them going into withdrawal. And unfortunately, because of methadone's pharmacokinetics, the way in which it reaches steady state it takes 5 days to get to steady state. A lot of times the dose that is going to be effective is not holding the patient for the full 24 hours. You need to minimize that in the pregnant patient because you don't want mom and baby going in and out of withdrawal. So sometimes you have to increase your dose a little more rapidly than you would under normal circumstances. A lot of people actually have the luxury of hospitalizing pregnant women and getting them stabilized in the hospital. That makes it really easy because what you can do is write a 6-hour dose. Start on 20, 30 milligrams and add 10 milligrams every 6 hours as needed for physiologic withdrawal. That's not for craving. That's not for I want it. That's not for can I stand at the nurse's desk and irritate everybody until I get it. It's for physiologic withdrawal. For those of you who do not use scales to measure physiologic withdrawal, I would definitely recommend it. Most patients in early treatment are unable to really distinguish between physiologic and psychological withdrawal. And if you've got the patient in the hospital particularly, or if you've got them in an inpatient or a residential setting where they don't have access to anything on the outside, what you really need to be adjusting the dose for is physiology, not psychology. Psychology requires support and therapy. It doesn't require medication. Physiology requires medication. And as I say, if you've got them in an inpatient or a residential setting where you can actually do a clinical opiate withdrawal scale and see what the score is. And if the score is 5, they don't have physiology. They may be feeling antsy and they may be psychologically wanting a dose, but they don't need it. Now, if you're in the outpatient setting, it's a little bit harder to gauge, but I would probably be a little bit more liberal on the run-up. But you need to ask the person, how did you feel 4 hours after you took your dose? And if they tell you that they felt really, really good, then you're probably too high as it is. And you really do need tincture of time here, and just hold off on increasing the dose and let them see how it works in 3 days. If, however, they are not, sorry, I'm trying to go backwards here. Yeah. If they're feeling pretty good at 4 hours, and they're not physiologically sick at 24 hours, stay where you are for a few days and see how they're doing. I usually am pretty liberal in going from 20 to 30 to 35 to 40 to 45 to 50. And then I wait. I hold it back and see how they're doing, because it's truly amazing how many patients will physiologically stabilize on 50 to 70 milligrams a day. It may not hold all of their craving, but it holds them physiologically. And that's when you're trying to get the dose up so that the patient, mom and baby, are not in withdrawal. That's what you want to achieve, is physiologic stability. You've got some time to work on the psychological issues, and you may or may not need medication for that. But we've already talked about the fact that if they're over-medicated at 4 hours and they're feeling really good, just make sure that you don't increase that dose, because unfortunately some people want something that the medication can't give them or shouldn't be giving them, which is to feel intoxicated. A well-maintained patient should neither be intoxicated nor in withdrawal. So if you look at what happens here with a patient who has a low level of tolerance, and you start them on a dose, this is the same dose, no dose increases here. And you give them a dose on day 1. As you see, they feel pretty good, but they'd really like to feel better. On day 2, you give them the same dose, and their blood levels go up, and they're running close to intoxication here. At the end of day 2, they're not even in, they're barely back into the therapeutic window. They're still feeling really good, but you know what? They're not going to volunteer that unless you ask them. So you give them the same dose again, and you've clearly got an intoxicated patient by day 3, 4, 5, 6, and 7. So what you see here is exactly what happens with methadone blood levels. On day 1, it's at one point. On day 2, it's at a higher point. On day 3, higher yet. Day 4, higher yet. And it's not until day 5 that the blood levels reach steady state and stop going up on the exact same dose, which is why sometimes it's difficult to gauge how you do that induction with patients. What should have happened with that patient is when you see what happened on day 1, and particularly on day 2, you knock the dose down. And yes, the patient's going to be not happy. What do you mean you're decreasing my dose? Well, I would rather not have you overdosing on my medication. So yes, we're going to decrease the dose. And as you see, it still takes a couple of days for that decrease to come back to steady state. But you've got them down 10 milligrams from what you had them, and they're still in the therapeutic window. And now they're not intoxicated, and they're not sick. So that's what you really want to accomplish. If, however, your patient has significant tolerance, they've got moderate tolerance, you give a dose on day 1, and they're nowhere close to the therapeutic window. I felt like crap all day long. I didn't sleep last night. I feel like crap right now. I'm in withdrawal. You do need to increase the dose. So on day 2, you may increase 5, 10 milligrams, whatever you think is appropriate there. And on day 3, you may still need to increase. And in this simulation, or even on day 4, you're giving a dose increase. And then you wait. And what happens with that dose on day 4 is a few days later, they're perfectly stable in the therapeutic window. Part of this is the art of science of medicine, and part of it's the science. Because do you give 3 increases? Do you give 2 increases? And part of it is what you see in your patient during the day. How were you feeling? Did you feel well at any point in time? And what you see here is on day 4, they felt okay 4 hours in. They may not have felt perfect 24 hours after their dose, but they were feeling good for a significant portion of the day. When you get that answer, that's when you stop increasing and you let time take its course. So a couple of things. No matter how bad your patient tells you their withdrawal is, it does not necessarily mean that they have extremely high tolerance or that they need to start at 80, or even that they may even get to 80 or 100 or 120. And I've had those requests too, and I'm sure that a lot of you have also. So you really can't gauge what the dose is going to be based on the severity of the withdrawal. Screen. Do urine or buccal screens early and often. I do them on admissions. I do them twice a week if I can do it. I do it as much as possible during stabilization. For one thing, unfortunately, many of our patients, shall we say, supplement their methadone with something on the street, either heroin, oxycodone, Vicodin, whatever it is that they feel like using. So I frequently do urines and do instant opiate screens. Document the signs and symptoms of withdrawal with at least 2 objective signs. I usually use the clinical opioid withdrawal scale. Anybody can do it. It doesn't take an MD, but you get a very clear indication of where your patient is physiologically. And then document the daily assessment during the induction and why you're making your dose changes. If you're increasing or decreasing, the reason for that needs to be documented in the patient's chart. Maintenance, one of the big things that everybody talks about. What is adequate dosing? Optimal responses from opiate agonists in maintenance treatment is to prevent the onset of withdrawal syndromes for at least 24 hours. Reduce or eliminate drug hunger or craving. And get enough methadone in place so that if they do use illicit opiates, they don't feel the effect of the illicit opiate. And I've literally had patients come in and go, can I go down on my dose? I tried to get high last night and I couldn't. Okay, no, you can't go down on your dose. Why don't we work on other coping mechanisms than getting high? But you do want that blockade in place. And adequacy of dose is based on 2 factors. The amount of medication. What is the dose that the patient is on? And then the frequency of dosing. And normally for methadone, the frequency of dosing is every 24 hours. It's once a day. You will sometimes have patients who need more frequent dosing. And pregnancy is one of the times when a lot of people need more frequent dosing. And how do you figure out what's dose and how frequently it needs to be administered? You need to individualize it. You cannot say that everybody in your clinic is going to be on 80 milligrams. Or let's be very specific, and I had somebody do this to me once. Nobody on my clinic needs to go over 88 milligrams. How interesting. Okay. It needs to be individualized. And a lot of times patients will overestimate what their dose needs to be. But that's where the clinical expertise comes in saying, you may think you need 120. Let's see what you need as you stabilize and as you are into maintenance. So what you want is an adequate dose that's based on clinical response. And that is enough medication to produce the optimal response for the appropriate duration of time with a margin for effectiveness and safety. I cannot emphasize too strongly that you have to make sure that what you're doing with methadone is safe. It's an extremely effective medication. It also is, in the wrong hands, can be extremely toxic. And the other thing is, and this I referred to a little bit earlier, the clinician and the patient need to speak the same language to ensure realistic expectations and goals of opiate treatment. What this means is some of our patients would prefer to use methadone as what I refer to as a floor, so that they don't go into withdrawal, but they can get high on top of it. I prefer to use it as a ceiling so they don't go into withdrawal and they don't get high. And sometimes a pattern of dose escalation is in pursuit of the elusive abnormal normality. And this needs to be recognized by both the patient and the clinician. Unfortunately, we also have the number of patients who, when they can't get an intoxicating effect from their opiates, they decide to supplement with benzodiazepines, which definitely does have a synergistic effect with methadone in giving an intoxicating effect. So we need to figure out how to deal with that in a different fashion with the patients. I always have that discussion with my patients, and I'm sure everybody else does too. So what's the maximum dose? There isn't one. Arbitrary dose ceilings do not have any foundation whatsoever in science or in clinical practice. And all saying a dose cap, and I sincerely hope that nobody out there has a dose cap anymore. We certainly used to have them. There was a program not too far from where I was practicing at one time that had a dose cap of 40 milligrams, which was absolutely insane. All it does is ensure inadequate treatment for a significant proportion of patients. And it's not supported by science. It's not supported by any of the professional organizations. You can't say that there is no patient who needs to go above this dose. Now, do I think that most patients need 300 milligrams? No, I don't. But do I think that some patients need 120? Yes, I do. The average dose in my clinic right now is running right around 100 milligrams. That means some patients are over 100. A lot of them are 100. But you can't put an arbitrary dose ceiling or cap in place. And then we always get to the big question, methadone blood levels. Should I do them on everybody? When do I do them? Why do I do them? Do I do them just because somebody tells me to? Plasma levels for methadone follow this type of a pattern. What you see is a relatively slow uptake so that you reach maximum plasma levels at about 3 to 4 hours, and then they gradually fall over the next 18 to 20 hours. But what you see on this, and this is a maintained patient, because at time 0, they already have 275 nanograms per mil on board, and then they go up to 450. And if you notice what happens with this patient is exactly what we talked about having happen with your patients. They're down to about 275 in the morning. So they're staying within that therapeutic window. We know that that plasma levels in the 400 to 600 range are where most patients are stabilizing. That's not to say that one of your patients may not stabilize at a much lower plasma level, or that they may not need a somewhat higher plasma level. But most of science would indicate that between 400 and 600 nanograms per mil at peak is an adequate dose. One of the reasons why it is important to know something about the plasma level is sometimes when our patients aren't doing well, our first instinct is to say what they need is more therapy, not more dose. And sometimes what they need is more dose. This was actually a study done by Dyer again in Australia. And what they're looking at is holders and non-holders. Holders are patients who reported being comfortable for the 24-hour period. Non-holders are patients who reported that they were not feeling well by the time that they got their dose in the morning. And what you see here is an indication of depressed mood and anxious mood, or total mood disturbance. And as you can see, in patients for whom the dose does not hold, you have significant mood disturbances versus the patients who are well stabilized. So patients sometimes do need that increase even when your gut level or your normal practice would say they don't. Sometimes they do. And the fact of the matter is, if patients are seeing this kind of mood disturbance, they're going to seek relief. If it's not being addressed adequately by the clinic, they're going to seek relief in what we don't want to see, and that's usually illicit drug use. So what you want to do is define the peak to trough ratio. One plasma level doesn't tell you much. You need a peak and a trough. When I do this, and I do it more frequently probably than most people do, I get a plasma level drawn before the dose is administered in the morning. And then I have the patient wait 3 to 3.5 hours, and they have to go back the same day and get the plasma level drawn again, so that I get both the peak and the trough. Because what I want to see is what's the difference between the high level and the lowest level. And the reason that I want to see that is we can determine whether or not a person needs a split dose based on how rapidly the level falls. So you want to define the optimal dosing interval to maximize the benefits and figure out, what's going on with this patient. You want to look at suspected drug interactions, because there are drugs that cause methadone to be metabolized more rapidly and more slowly. And you want to look at whether or not a split dose is justified in a patient. And then monitor the effectiveness of the divided dose schedule if you determine that you're going to go that way. Peak and trough levels alone don't usually tell you whether or not the dose is right. It may tell you the dose is wrong if you're coming back with a peak level of like 1,000 nanograms per ml, but it's probably not going to tell you if the dose is right. Dose adequacy is usually determined clinically, not by a plasma level. And as I said, optimal levels for cross tolerance or for blockade are thought to be in the 400 nanogram range and up. But if you have a patient who has a peak to trough ratio of greater than 2, your dose probably isn't holding for 24 hours. That suggests rapid metabolism. And it could be due to a number of issues, one of which is pregnancy, particularly in the 3rd trimester. So what you're looking for when you look at your serum methadone levels is a rate of change. And in order to get a rate of change, you need 2 plasma samples taken at appropriate intervals, one before the dose that day and one after the dose that day. So what happens if your patient says the dose isn't holding? Well, first of all, what's going on? Is the patient in a supportive environment that's going to help him or her maintain sobriety? Or is the fighting at home outrageous and everybody's using around them, etc.? Are there stressors? Well, needless to say, especially when we're talking about pregnant ladies, they have stressors. So how are you going to manage the stressors? And sometimes that's an increase in dose and sometimes it's not. Are they doing something else they shouldn't be doing, like drinking? Are they taking other drugs or medications? And that happens a lot even with pregnancies. Ladies are frequently on antidepressants, etc. So are those affecting them? Are they on vitamins? And they better be if they're pregnant. So is that interfering with the metabolism? Urinary pH, nobody pays a whole lot of attention to anymore. And then you clinically adjust the methadone dose. Sometimes, particularly if your patient is just feeling uncared for, you'll have 5 milligrams and it's amazing how much difference it makes. Sometimes it doesn't. Sometimes you really need to have a good plan in place to address the environment with stressors. And particularly if the patient is using other illicit drugs, you need to make sure that that's not something that they're going to continue doing. And then do you need to get blood levels? If I'm at 60 milligrams, I'm not going to get blood levels. I'm probably going to go up on dose if I think that's the appropriate thing to do. If I'm at 100, I'm probably going to get blood levels. But that's just me. So not holding strategies. You want cognitive and behavioral interventions. Increased contact, counseling, and therapy. Again, don't worry about the pH. Is the patient using? If the patient's using opiates, you probably have to raise the dose. Most patients don't continue using and wasting money if they're not feeling the illicit drugs that they're using. If they're using something other than opiates, then you have to address it with the cognitive and behavioral interventions. And then you have to determine whether or not you need a split dose. Some of the medications that can severely affect methadone's metabolism are, and what it means by induction, is that it induces the metabolism of methadone, meaning that the methadone is metabolized more rapidly. One of the big ones is rifampin. If you have any of your patients who are diagnosed with a tuberculous disease, Mycobacterium avium or tuberculosis, they should not be on rifampin, they should be on rifamycin. Rifampin is probably going to drop their plasma levels of methadone by half. And you end up with split doses, and you end up with uncomfortable patients, and it's a mess. Rifamycin does not cause the drug-drug interaction. Phenytoin definitely induces, it's not to the point of a half, but you frequently have to split the dose of methadone if the patient is on phenytoin. Alcohol does increase the metabolism of methadone. So if your patients drink, they need to stop drinking. Barbiturates also induce, as does carbamazepam and several of the HIV medications, particularly the protease inhibitors, and in my experience, the worst one is efavirenz. That'll drop those plasma levels by 50 to 60% inside of a week. And it's not all uncommon to get a call saying, I don't feel good at all, for a patient who was previously pretty stable. So if the patient is complaining of waking up sick, but is sedated 3 to 4 hours after the dose, why do I have that? Okay. A lot of times when a patient comes in and says that their dose isn't holding and they're on one of these, our first inclination is to simply increase the dose. Sometimes that works, sometimes it doesn't. If what you accomplish by increasing the dose is that the patient is sick in the morning, but they're sedated 3 to 6 hours after the dose, increasing the dose is not going to be helpful. What you need to do is increase the frequency, and that's when we get into split doses. And what happens with a single dose before you increase it is the purple line. And as you can see, the person is sick in the morning, relatively normal during the day, and sick again in the morning. Then you realize the patient's uncomfortable, you increase the dose. Now they're sick in the morning, they're high later in the morning, and they're sick again the next morning. So what you want to do is split the dose so that you get the yellow line. And so that instead of getting one dose that holds them in that normal zone throughout the day, you have 2 doses that hold them in the normal zone throughout the day. And unfortunately, this happens a lot with pregnancy, particularly in the 3rd trimester. The patient will come in and say that they're waking up sick and that the baby's moving. Well, the baby's moving because the baby is also in withdrawal. And it is not at all uncommon to have to either raise the dose or split the dose during the 3rd trimester and sometimes the late 2nd trimester of pregnancy. And so that what you do, instead of having a peak to trough ratio of 3.4, as the yellow dose shows, with the purple dose after you've split it, and all you've done here is you've taken their daily dose of 80 and split it 40-40, is you now have a peak to trough ratio of 1.4, which is less than 2, which is your cutoff point. So if you are going to be splitting, what you want, do not have your patient come in sick in the morning and give them half a dose. They are not going to be happy with you, and it's not going to work. You're probably going to have to give them their full dose in the morning and then give them another half dose to take in 12 hours. And then on day 2 and beyond, you go with the half and half every 12 hours. But if you just give them half a dose in the morning of day 1, they're not going to be feeling good at all. Sometimes just splitting the dose isn't really adequate. So what you might need to do is go up totally. Now this is actually a different one. This is for the patient who was sedated at 3 to 4. So rather than give them the whole dose because you know that that's too much, you give them 60% or 70%, make an educated guess, and then you give them the 50% later on, and then 50%. And you may need to titrate it up and down. Sometimes what you end up with is 60% of the original dose every 12 hours, so that you actually increase the dose by 20%, but the patient's more comfortable and they're stable. So how do you, what are the evidence-based practices to maximize your outcomes? Having an adequate dose. Don't try and underdose your patients. Availability of counseling. Medication is not the whole answer. These patients need to make life changes. And then maintenance versus abstinence or detoxification program orientation. Dr. Walter Ling out in LA has a saying that I think is absolutely brilliant, and that is detoxification is good for many things. Treating opiate dependence is not one of them. It just doesn't work very well for most of our patients. Patients who come off of, who detox and try and make it drug-free, you've got over a 90% relapse rate. Most patients require at least a period of maintenance so that they can get their lives together and then see whether or not they can go drug-free. And then contingency management with focus on positive and immediate reinforcement. Why am I emphasizing methadone in this case? The effects of untreated opiate addiction or detoxification. You have an increased first trimester spontaneous abortion rate. You have an increased third trimester premature labor rate. You have low birth weight. You have NAS, and you've got other problems associated with the pregnancy. If your patient is absolutely adamant that they want to detoxify, the first trimester or the third trimester is not the optimal time to do it. If they really want to go drug-free before the birth of their child, try it in the second trimester. And if it doesn't work, get the patient restabilized so that during that third trimester, when the baby needs to be putting on weight, they can put on weight. There is no evidence that higher doses of methadone are harmful to the fetus. The neonate does have a probability of having neonatal abstinence syndrome. And for that reason, delivery needs to be arranged for a hospital where the neonate can be appropriately treated for the NAS if it's necessary to treat them. We can get into treatment if you want to, but I will tell you right now, I do not favor treating the neonate with methadone. I have always been taught, and what I recommend is that the neonate be treated with morphine or tincture of opium, but not with methadone. And sending an infant out of the hospital on methadone, to me, makes no sense whatsoever. So I'm going to stop there and see if we have any questions here. And I'm going to hand it back to Kristen.
Dr. McNicholas, can you hear me?
I can hear you.
Okay, good. I just have a couple questions that might have been answered during the presentation, but I'll just go through these. The first one, if a pregnant patient has been stable on her dose of Subutex for months, is it possible that she could need an increase? This particular patient seems to feel she does.
It is possible that she may need an increase. It's also possible that other things are going on, including hormonal ups and downs associated with pregnancy. In the mother study, which was published in December, the average dose for the ladies who were maintained on buprenorphine monoproduct, the Subutex product, was 14 milligrams. However, there were patients who were over 16. So yes, she may need an increase in her dose. She may not. And part of it's going to be what's your clinical sense. Is it going to help her? The last thing you want is her going out and using something else. The data on that is less clear than it is with methadone. With methadone, we know that they frequently increase, need an increase in dose towards the end of their pregnancy. With buprenorphine, we don't have as much data yet.
Okay, then the other question is, how many hours should optimally be between doses for someone who is splitting dosing?
I have very rarely needed to go more than 2 doses a day, every 12 hours. I have heard of instances where patients need to go every 8 hours. I have never been in that situation, and I thank God I never have been. I think it's theoretically possible that you have somebody who's metabolizing that rapidly, but I think that it's very rare and few and far between. It's usually twice daily.
Okay. And then I think I've got one more here. Oh, is it usual for a baby in withdrawal to take 3 months to be released from the hospital?
No. If your neonatologist and your nursery staff know how to manage neonatal abstinence syndrome, and it's just neonatal abstinence syndrome. Now, if the baby has other issues, then all bets are off. But if it's just neonatal abstinence syndrome, most of what I hear is 2 to 3 weeks max. A fair number of, and actually in the mother study, which was methadone versus buprenorphine, the average length of stay was between 10 and 12 days for methadone, for babies born to methadone-maintained moms. And so, no, 3 months is not normal.
Okay. Here's another question. We have many pregnant women who cannot afford the treatment anymore in the middle of pregnancy. What is the safest way to detox them or to help them without the high risk of abortion for the baby?
First of all, see if you can find funding for them. Medicaid won't pay for their continued treatment. That's not a good situation. If you have to taper, the second trimester is the safest period of time, but to be perfectly honest, there is no safe period of time. And I would really be searching for funding sources or for a program who can take them on a funding source that if you can't take that funding source. I would look for a transfer for them before I started to look for a detox. For one thing, I mean, if you detox in the second trimester and they relapse in the third trimester, then you've got the worst of all worlds. So I would definitely try and maintain them or transfer them to a program that has funding sources or resources that you don't have.
Okay. It looks like we can increase if the pregnant woman continues, it must be, can we increase if the pregnant woman continues using crack and alcohol but stops using heroin?
You can increase, I'm not sure how much you're going to accomplish by increasing. I certainly would not say never increase in that situation, but I think what you need to also look at is how can you increase the cognitive and therapeutic support for this person to stop using cocaine and alcohol, because increasing the dose of methadone is unlikely to have much effect on either of those 2 drugs or on the benzos that they may also be using.
Okay.
And so it's not out of the question, but you need to look at other behavioral modalities for addressing those issues.
Mm-hmm. Somebody's asking for some reliable references and citations regarding detoxing while pregnant. Now, I think at the end of one of the PowerPoints, anyway, are some references and resources.
Yeah, so Jan has those.
Those available when I send out the information after the webinar. It says, what is the average stay?
For the neonate?
That's all it says.
Okay, I would guess that that's the neonate, but I think that I just answered that. And normally I would say about 2 weeks for a methadone-maintained baby is not unusual.
Okay.
Or a baby born to a methadone-maintained mom.
Okay. We can only do split doses for pregnant patients who are eligible for caries. Many of them are not. What do you recommend with them?
I think that whoever is making up absurd rules needs to be addressed because if you can split them for some patients but not for others, that makes absolutely no sense whatsoever.
Should we encourage the moms to breastfeed?
Yes.
Yes.
Okay. Let's see. It says to please repeat the peak to trough level that indicates dosage not holding.
If your peak to trough ratio is greater than 2, then the person is probably metabolizing too rapidly to be held by a single dose per day. So basically, if I get a peak to trough ratio of greater than 2, I am looking at the potential for a split dose.
Are you at all familiar with inpatient treatment facilities in Southern California that allow the pregnant woman to continue with OMT?
I am not, but I would suggest that you contact Judy Martin in Oakland, California. Dr. Judith Martin. If you need more information.
You know what, we can look that up and then give that to them on Monday when I send them the other information.
That's perfect, but I would speak with Judy about that because she knows pretty much the whole situation in California.
Okay. I had a CT whose baby was placed on morphine, phenobarbital, etc., then later placed on methadone. Is that normal?
No.
Not with the neonatologists that I work with. First of all, there's usually, unless there's sedative hypnotic abuse in the mom, there's usually not any reason to use phenobarbital. And why on earth the neonate was not tapered off of all medications but was placed on methadone is beyond my comprehension.
What if the patient is found diverting the split dose? We have changed them back to single dosing and daily being seen in the clinic. Your comments?
That one's a tough one because, yes, I've had it too. And my response is pretty much the same as yours, and that is if you can't be trusted to take your dose home at night, then you're going to have to deal with the fact that you don't feel very good. If you're really, really lucky, you've got somebody who can, you know, who has a clinic that has dosing hours at 6 in the morning and 6 at night, but that's few and far between these days, and so sometimes you basically are trying to make the decision as to how you best keep the patient safe and the public. And if the patient's diverting the medication, then I completely can understand why you're saying they can't have a take-home dose.
Is there any legal protection for pregnant women who are incarcerated during the treatment?
I'm sorry, repeat that.
Is there any legal protection for pregnant women who are incarcerated during the treatment?
If you mean legal protection for treatment, that's probably going to be jurisdiction by jurisdiction. Some jurisdictions will allow treatment in prisons or in jails, and some will not. Some will allow it for pregnant women and not for other people. So you really need to find out what you can arrange with your local authorities.
Okay. In East Orange, New Jersey, we have an intensive outpatient methadone program that provides free treatment to women and pregnant women funded through State Department of Addiction Services. So that must just be a comment. If anybody,
that's a comment. So anybody in New Jersey who has trouble, you know where to give a ring and get some help.
Can you repeat what you said about vitamins and vitamin C?
Vitamin C has a tendency to increase the metabolism of methadone. You have to be on pretty large doses, but I mean, your pregnant ladies should be on vitamins. So you may need to increase the dose. I've never had to have split a dose based on vitamins, but I have had to increase the dose based on vitamins. And so I would just make sure that the dose was adequate, and because they are going to need the supplemental vitamins for the pregnancy.
My patient wanted to decrease her dose as soon as she delivered. The doctor and I thought it was not a good idea. Feedback, please.
Actually, most people would recommend that you do start decreasing the dose shortly after delivery. A lot of times, particularly with moms who have had to increase their dose during the latter stages of pregnancy, it's because of the volume of distribution going up. In other words, all the water weight that they're carrying, along with all of the water involved in the placenta and the pregnancy itself. And as they start dropping that, and you know, everybody knows ladies drop that at different rates, but as they start dropping that, it is usual for their dose requirement to go down. So most people would say to start dropping by about 10% shortly after delivery, and then adjust the dose appropriately as mom loses a lot of that water weight and baby weight.
Okay. Is the severity of NAS dependent on the maternal dose?
The severity of NAS is not dependent on maternal dose. There is a lot of talk about that, but there's very little science to support that. Some ladies who are on relatively low doses, the baby may have relatively severe NAS, and other ladies who have a higher dose, the baby may not have any NAS. It seems to be somewhat idiosyncratic. Probably about 60 to 65% of the babies will have some NAS, but it is not dose related, as far as we can tell.
Okay. What would a peak trough ratio of, write this down, 1.06.0.35 indicate?
1.06?
Yeah,
indicates that
0.35.
The peak
trough.
The peak trough ratio is 1.06.
Yes.
It's perfect. Actually, that's about as flat line as you can get for blood levels. Basically what that means is that it's not changing much at all between peak and trough, which means one of two things. Either they're not taking their, either you've got the dose absolutely perfect, and you have a perfect patient, or what they're saying is a trough may not be a true trough. And sometimes I have been in the position of patients who have take-homes and they say that it's not holding and they want to peak and trough, and I get numbers that make no sense, and I say you have to do it again, but you have to come in for a week every day and get medicated so I know when the peak is and when the trough is. I've never had a patient with 1.06. Usually for me it's closer to about 1.2, 1.3.
How much methadone is in breast milk?
You get some, but you don't get a whole lot. And it used to be that we said that moms should not breastfeed, but that's pretty much gone by the wayside.
Okay. Let's see here. The next one is, some prisons will not continue the treatment for pregnant women. Is there anything that they can do?
That's a good already.
Excuse me?
Again, I would simply work with my the local authorities, and if you've got a really good case, take it to court. It's amazing how sometimes the judge will disagree with the sheriff or whoever's running the local jail. And Lord help the jail if mom has a spontaneous abortion because she was detoxed off her methadone.
I would like to use motivational skills with pregnant women. Any others you'd recommend?
Well, I would definitely recommend some CBT, cognitive behavioral therapy, so that the patients can learn some skills in dealing with a variety of things, because Lord knows being a new mom is not going to be all that easy on them. And so I would definitely, in addition to motivation, go with some cognitive behavioral therapy, and then supported therapy. A lot of these ladies have very little support that they can actually count on the outside. And if just knowing that they get some supportive expressive therapy can be really helpful.
I think this next question might have been answered previously, but I'll go through it anyway. You said we should advocate for mothers on methadone to breastfeed. If that is correct, why? Would that not continue the infant's dependence on methadone?
You get some crossover in the breast milk, but you don't get enough so that the baby is going to really become dependent on it. If you're really uncomfortable with it, then you need to use your best judgment. And part of it, I imagine, is going to be based on dose. I'm not sure that I would be completely comfortable if I had a lady who was requiring 150 milligrams a day. But usually with transfer, I mean, you're looking at blood levels in the nanogram per mil range. That's what your transfer is maximally going to be. And that's probably not going to be enough to really affect the infant.
Okay. I think I have an answer here to somebody's previous question. It says in Southern California, San Diego, KIVA will treat a pregnant mom on MMP.
Okay.
And then there's another breast milk question that was answered. Can you comment on the role of the OBGYN? Can you comment on the role that the OBGYN should take with pregnant moms on methadone treatment and recommendations for best practice with these types of patients?
Well, first of all, most people would consider a lady who is addicted and in treatment for opioid addiction to be a high-risk pregnancy. So your OB needs to be familiar with practices for a high-risk pregnancy. And I don't know how specific you want me to be. I mean, the best treatments would be integrated with the OB and the methadone maintenance treatment program working together to manage the patient. The one to manage the physiology of her pregnancy and her delivery, and the other to manage the psychological aspects and the physiology of her addiction. And and one of the things that I think that we all need to be aware of is if you have a person who is not pregnant on methadone, you should be getting pregnancy tests monthly. And if it comes up pregnant, you have to get the person into prenatal care ASAP with an OBGYN who understands high-risk pregnancies, and you have to be able to communicate with them. Neither you nor the OB can be operating in the dark, and so there has to be joint management of the patient, but it should be a high-risk pregnancy OB.
And some of these questions are also going to be answered in the second half of this webinar, where Jan Cusero, RN, will be speaking about aftercare and working with the pregnant moms as well.
Yeah, and I was going to say, I mean, we can answer a bunch of questions later with both Jan and I on the phone or whatever, too.
Okay, well, I can stop there then. And I will just hold the rest of these for later. And I hope people keep sending in questions, because that'll be good, so we'll have a nice discussion afterwards.
Right.
Okay, Dr. McNicholas, I'm going to mute you now and then turn this over to Jan Cusero. Okay. The next presenter is Jan Cusero, RN. She is the Special Needs Unit Care Manager with Gateway Health Plan in Pittsburgh. Okay, Jan, can you hear me?
I can.
I know she was ready to go. Hold on just a moment, everybody.
Okay, I'm going to talk a little bit about opiate use during pregnancy, the management strategies to improve the outcomes of the mother as well as the baby and the entire family. And I hope by the end of our talk we'll be able to identify some of the issues that caregivers in a variety of settings need to know that will improve the outcomes of women that use opiates during their pregnancy as well as afterwards, and their children, and explore some of the challenges that present to caregivers in treating pregnant women and using their children. If you tell most providers that there's a call or an appointment coming up and it's about a pregnant, addicted woman, you kind of get this look. You get a baby. Here's a picture of a baby going, oh my goodness, not another one. How are we going to handle this? It presents a lot of challenges in the management of pregnant opiate-dependent women. It's complex, and these challenges occur at almost every level of contact. And some of these challenges that are presented in the various settings are how do we know if the mother is in treatment? How do we get her in treatment if she isn't? How do we know what her treatment plan is? What does she do with treatment? Does she go to therapy? Is she on methadone? Is she not on methadone? What is her goal? Is it a good treatment plan? Is it one that, she's self-directing but without information? Is it one that's a provider perhaps that doesn't know all the ramifications of, say, detox during pregnancy or about appropriate treatment? Is it a good treatment plan? How do we know she's getting OB care? Working at an NTP, do we know that she's getting OB care? Do we have that confirmed? Do we know she's keeping her appointments? Is it appropriate OB care? How do we know that she's following good health practices during her pregnancy? How do we know she'll know how to care for her baby when she has it? How do we know if the baby will be treated, and how will that baby be treated? How do we know that the home will be safe for the baby to come home in? How do we know that the parents will keep all the follow-up appointments for the baby? When do we call Child Protective Services? What can be done to improve the outcome of the child? And does anyone really care what happens to the mother or father? Is it all based upon the baby? I think overall, the biggest challenge that hits most of us, and the most important one, is what can we do to improve the overall outcomes of the baby, the mother, and the family? Because what we know is if the mother is treated appropriately and the whole family situation is intact as much as it can be, that the outcomes in the babies are much better over time. And that's the biggest thing that we want, is to have good outcomes. And so that is our main challenge. And so when you feel these challenges, understand you're not alone. Estimates range from 11 to 19% of all newborns will have had exposure to alcohol or other drugs in utero. 10% of all pregnant women will show positive for illicit drug use sometime during their pregnancy, if they're tested. Not all women and infants are screened and tested for alcohol or other drug use and exposure. And despite well-researched and documented studies making recommendations for the care of pregnant women using opiates and their newborns, these recommended protocols are not followed. There's still folks out there kind of doing their own thing, and I think Dr. McNicholas very clearly stated that, is that there are recommended protocols that are based upon well-funded research over time dating back to Loretta Finnegan's studies that still hold true today. And those studies have been replicated over time, regardless of how opiates have changed, going from, say, heroin in the 1970s and 1980s that was not very pure. You're lucky if you got a purity of about 20%. That would be considered good dope at that point, where now opiates are either pharmaceutical or even the street heroin at a very high purity level of 90%. The same principles follow through, and the mother study that Dr. McNicholas talked about alludes to the same information with mothers today, and even with prescriptives like buprenorphine. And so, they're pretty translatable, but there's folks out there that still want to do their own thing, but I think it's because they don't know or they don't understand, and because of the challenges that are presented at all of the levels. There's still a misconception that once the babies are withdrawn effectively, that the care needs for them are completed. Okay, we got to get them through withdrawal, and once we get them through withdrawal, everything's going to be okay. Some studies have indicated that behavioral and growth disturbances are also manifested, and those are on some of the Australian studies as well. there have not been conclusive studies as to what the specific longer-term outcomes are in the children, but we do know that there are strategies that can improve the shorter-term outcomes, and that over time, allowing for overall improved development and satisfaction of the mothers, which obviously leads to a lot of better parenting environment for the kids. As professionals in the field of perinatal addiction, we have to continue to address these challenges because we really need to improve the outcomes in the mothers. Dr. McNicholas previously gave us some information about how often drug use in pregnancy occurs and, about the methadone maintenance. But we have to take a look at some of this as an opportunity for treatment. And as she talked about, the pregnancy serves as a motivator for treatment. And if you ask most of the women, as I have over the years, whenever I see them at intake, and oftentimes visiting them at the hospital, maybe during inpatient induction or what we call conversion, interchangeable types of terminology, we would I would always ask them, I said, well, what's the big reason now? Well, for the baby. I'm doing it for the baby. Well, would you have needed treatment? Well, I think so. Would you have gotten treatment? No. It kind of tells them about where they are in terms of understanding their addiction and their esteem, and the baby becomes a motivator. We know that it is not just enough, and eventually that has to translate over for self-motivation, but while we have that precious little package, we need to use that as a motivator and help with that. And that really does start with, some strategies. And I think it begins at assessment. I think many times we're not assessing for really what's going on with that person at a real comprehensive level, and it requires that. And I'm going to say first, it doesn't even occur with the mother or the person presenting for treatment. It occurs with the person who is the gatekeeper, if you're the interviewer. You really have to examine your own attitudes and beliefs first about substance-using women and their children. I've had a lot of women that work in OB fields, as nurses or clinicians that work in the NICUs, and they are just so angry at the mothers. And just how can you do this? And I've had physicians working, doing dose adjustments in the hospital, and they really just don't want to be bothered with this population of patients. And if that's the case, I let them know that that's okay, but they probably shouldn't be the ones treating them. It should be in a different environment. We really need interested people that are looking at how to, strategize and to be able to accept that personally and to be able to say that their attitudes are not going to be getting in the way of that treatment. We want to identify then the strengths and supports in that family. And mothers generally don't stand alone. They may come to treatment alone, but they're not standing alone. Understanding that children of addicts are, have a 3 times more of a rate of becoming addicted themselves, and understanding that most of the women that come into treatment, 80% of them said one or more of their parents had a drug addiction, many of them using with their parents or siblings or family members, and even with initial use, which is a different concept today than what it had, in the past, I think, whenever I began working in the field. However, they also, most of the women have addicted partners, that they're in relationships, like, romantic relationships, and they wind up having addicted partners or partners that are invested in the mother's addictions. And so, there's a lot of, factors with that, and those, can be strengths. They can be they can also be not so strengths. They can be actual barriers to treatment. And in that, identifying the strengths and what can be a strength part of that and what can be a barrier to that in reaching the goals of optimizing the care for the baby. You know, is the mom still more impacted by an abuse situation with the father? Is she tied into her parents not wanting to know that the baby was addicted, and so therefore she's making decisions based upon that? We have to really know where she's at in time and assess that. And we also have to identify a bunch of resources to address the barriers and support the strengths in the setting that each of us are working at. I understand we're coming from a lot of different areas, not just Pennsylvania, not just necessarily the drug and alcohol treatment aspect, but understand that OB providers wrestle with this, as well as NICU and pediatricians, and then in the communities, like public health nurses, early intervention. There's along the whole continuum. Everybody winds up, being challenged by this. And so we have to look at, in terms of treatment planning in the setting we're at, and how we can, extend that web of supports for dealing with the family in a community setting, involving not only drug and alcohol treatment, but family support services, child protective services, and any of the medical care services that the family is going to be involved with. And we started at admission, and we continue to evaluate and reevaluate the effectiveness of this, and it will certainly take an interdisciplinary team approach to make this become effective. Continuing with assessment, we have to look at alcohol and other drug use. As Dr. McNicholas pointed out, that many times women will relapse into other drug use, and we have to see, what is that? Is that a self-medication of anxiety? Is it trying to alleviate depression or PTSD symptoms? What is happening? Are they trying to get to that, slightly euphoric level, that, that abnormal normalcy phase that was on her slide? What is it that they're looking for? Most folks don't remember normal. They've been using for a while. If they've been born as children of alcoholics or addicts, if they've been in abusive relationships, if they've had an experience in their whole life, do they really know what normal is and what it feels like? And many times they don't know that, and so they're looking for just something that's comfy for them, and meanwhile that's not where it really is, and that comes through other medications, other therapies, other things to help stabilize them. Oftentimes, OBs don't even look for drug use in women, and amazing at this level that they're still not standardized. There are standardized questions, but they're not utilized straight across the board. Things like the opiate withdrawal scales, or the SBIRT type of questionnaires for addiction, whenever women aren't coming in for treatment, and that we wouldn't regularly tox screen all pregnant women intermittently throughout pregnancy. That's just something that's not done. People talk about cost. Working for a managed care corporation right now, I would much rather pay for some tox screens than I would, treatment down the road, ongoing for a period of time, because it's much easier to identify it up front than it is to kind of remedy it later on down the road. And oftentimes the drug and alcohol treatment professionals don't really understand all the ramifications of OB, ramifications or neonatal implications. And so it's really important that we continue that assessment for alcohol and other drug use on both ends. Pregnant addicts are a priority for drug and alcohol treatment, and I think oftentimes, in terms of assessment, I've heard people say, well, yeah, we have a pregnant woman, but, they just have to wait. And at least in Pennsylvania, the Division of Licensure has placed them as a priority, and so there are exception to numbers. Each facility has a number cap on it. there is an exception to that, and folks can get in treatment, and particularly people that are on for profit programs, that there is a transition process to an MA-based or sliding fee scale-based program by way of county funding and medical assistance so that they could get into an MA-based treatment program for treatment. And knowing where they're going for their OB care, where they're, whether we're talking with them, and assessing for comorbidity. Behavioral health comorbidity as well as physical health conditions must be addressed. Many times women have a host of infections, you know, whether it be from injection, whether it be from, you know, gynecological infections, whether it's other kinds of infections or sepsis even. You know, many times women have had those kinds of problems, and withdrawal has been listed as the source of the symptomatology. Meanwhile, they had serious health issues. Looking at diabetes, gestational diabetes during pregnancy has been discovered. Many other things that can be uncovered once a woman is stabilized on methadone in a program, and then you start to see what else is going on, and so assessment for that is so important. Pregnancy confirmation and making sure that there's OB care is so important, as well as a whole lot of psychosocial assessment. Understand that, you know, if there's addiction going on and not just occasional drug use, this life is coming to you is going to be very unmanageable in this woman. And so understanding that all aspects of the life will be affected, so addressing all those aspects in treatment and not just medical stabilization with a drug is going to be important. We have to look at overall recovery of that woman. Recovery not necessarily meaning drug-free, but recovery while they're in methadone treatment. All those recovery principles applying. When we talk about this, we're talking about things that involve confidentiality. And before we get into the interventions, you know, we do have to address the confidentiality issue under the laws of the federal government as well as the state. The federal confidentiality laws are very broad, but they also defer to the state, which are also sometimes a little bit more restrictive. And we have to understand that we can share information back and forth. I mean, many times that confidentiality issue is like thrown up, and it becomes a barrier to drug and alcohol coordination of care, where it doesn't have to. You know, folks just have to learn our language. Many times when I would do trainings with, like, say, Child Protective Services, I would say, well, you know, when I'm able to list out to you these 5 things, I'm able to give you, this is what it means. You know, if I say partially compliant, well, that means that, okay, you're in treatment and you're doing most of the stuff, but there's still some areas, you know, that we still got to tweak a little bit, where, you know, non-compliant means, you know, it's a wreck, you know, where it's not working. There's not a good treatment plan in place. We're not getting stabilization. We're not getting cooperation. We're not getting, you know, a buy-in to the treatment regime. People can understand that better, and it just means being able to talk and be able to translate our terminology a little bit better. But understanding, obviously, the guidelines of each state, since we're crossing some state barriers here into New Jersey and Pennsylvania, I mean, we have to defer to each restriction area for that. But I think there's a way through that. I know that that was one of the biggest things that in treatment, you know, whenever we approach pregnant women is, you know, I need to have you to sign for this, for me to be able to do this. We approach it in a way of coordination of care, not that we're telling on them, you know, that, you know, for me to be able to communicate and communicate effectively. Now, there's time frames. You have a right to withdraw this at any point. That's okay. But at least for now, let's try to get this so we can coordinate the care in the levels that we can. In terms of the assessment, if you're in an NTP, you need to assess the pregnancy and all the issues that go along with that. The OB setting, you need to assess the drug and alcohol treatment. And if you're a buprenorphine provider, you're kind of out there on your own, you need to link up and follow up with the resources that are available in order to address the needs of the pregnant woman. This is a special population for which coordination of care and very intentional follow-up has to be confirmed. In terms of intervention, Dr. McNicholas talked about the, induction to methadone, assuming that it's coming from opiate, another type of opiate drug. Maintenance treatment with methadone or buprenorphine during pregnancy is definitely recommended and is the best practice recommendation for treatment during pregnancy of an opiate-addicted person. Withdrawal from that is not a recommended treatment during pregnancy. Coordinated alcohol and other drug prenatal care is so important, and I've found in a lot of programs, I've been very fortunate to work in a very integrated program that, being part of a system that had drug and alcohol treatment as well as obstetrical care, pediatric care, delivery services, psychiatric services, the full spectrum that we need was so helpful, but at one point not having that same availability with a change in our health system, we were able to replicate that, but it took a lot of footwork. It took a tremendous amount of coordination in between the drug and alcohol providers and the prenatal care providers, the NICU providers, the folks that would see people on down the road, early intervention. But it is possible. And it is essential for the improving the outcomes because we have to know what each other is doing. I've had OBs try to adjust the dose of women in drug and alcohol treatment programs, and then I've also had drug and alcohol treatment programs that didn't even kind of know where the person was going for OB care or how often they were going or what was their OB telling them, and what were they doing, and finding out that there was recommendations being made that really weren't aware of. And just by talking, it made a lot of difference in the outcome. We have to provide a lot of education, and it just is right down the laundry list in terms about the effects of opiates, the what are the expectations of the outcomes? Many times folks don't really realize what they're going to be coming across whenever they just assume the tales that are told that babies are going to be in the hospital for 3 months and, the babies are going to have withdrawal and this is what they're going to look like. I always would tell the kids, the mothers that are in our program, the story about the visitors coming in and looking at our kids in the NICU, and I would have them say, okay, which one do you think is withdrawing? And they always thought they'd always pick out ones that were had the bells and whistles and, the ones that were most severe that everybody was huddling around. And they wouldn't even notice the mom and baby sitting in the corner with the lights dimmed, the baby, swaddled a bit in a blanket rocking in a chair. They never even thought that kid would have been the withdrawing kid. There's a lot of preconceived images, and remember that mothers have a lot of guilt and a lot of shame, and so their fantasy about what their kids are going to be like, that they did these terrible things to their kid is going to be pretty tremendous, and we sometimes have to dispel all those myths. But also understanding that their babies can go home and not have any issues is also one of those that are there as well, and we really have to talk about what the expectations are and also about what the management skills are. Many times people want to do things, and I think it's important to educate them about why you would not want to do that, what percentages, what are the consequences if they do that, what's the literature, what can other mothers tell them? And sometimes that is the greatest support, is having other mothers that have been through things, talking to them about that has been the overall factor that changed them. And so education, not just by the professionals, but the other people that are involved in her care, is sometimes important. we have to intervene by preparing women for parenting. It's just so important that they understand what this means, that this isn't like this short window in time, but further on down, and getting them to see the bigger picture down the road in terms of outcomes for their children. Their role as a mother being identified, not just, well, you're this person today, the addict, but you're a mother who happened to use during pregnancy, and now you're going to be a mother. Now what kind of mother do you want to be? How do you want that identification to be? And understanding that they have some choices about that. Having a lot of women-centered treatment. People always ask me, well, what does that necessarily mean? And I think that, women talk a lot about feelings. People want to talk a lot about, it's not all just in the head and problem solving and, okay, get to point A to B. There is that, but there's a lot of feelings underneath, a lot of things stirred underneath that need a lot of attention. And so, using therapeutic skills, as Dr. McNicholas says, cognitive behavioral therapy is very important, but also very motivational. Some of the questions was around the use of motivational therapy. It's tremendously supportive to this kind of treatment, and I think I would even say essential, because in the very beginning, you want to enhance that motivation, look at all the strengths as much as possible, and so coming for the very motivational approach to what this mother has done, and what she has succeeded at, and not always looking at what she has not done and what she still has to do, but being able to, get her to identify some of the areas that she wants to move forwards in, and help empowering her to do that, and understanding that that can be in a lot of different areas of her life. And things become more normal, and she begins to more manage her life. She has time now to do that. If you're using multiple times throughout the day and you're spending your time either, intoxicated where you can't think right, sleeping from the opiates whenever you're initially high, and then, heading in that really brief normal period into that period then of withdrawal and drug seeking and all the things you need to do that, you don't have time to do normal things, where, with methadone you have time to do these. And folks would always talk about the different therapies that we would use, and we tremendously relied upon group therapy to support the change. With that, and someone mentioned that they had an IOP program, which is really great, because I think most of the women that have addiction that are in recovery can benefit from an IOP setting, because they have their individual time as well as their supportive time and group time. But one of the things was doing it a little bit differently. Sometimes people would say, well, how can you get your women to come to your partial programs? You have them coming in every day. How do they do that when we can't get them to do it? Well, I would just ask them things like, okay, well, what are the things that you think will help you get to where you want to be with that? They said, well, okay, well, you say I have to come in each week. Yeah. Okay, that's the one time. And then what about, that parenting group, I think I want to be part of that. Okay. And that women's group, I really like that. Okay. And that recovery group, yeah. And then, I want to come in for the NA meeting. Okay. And pretty soon, and I want to talk to a child development specialist and outreach worker. Okay. Pretty soon they have themselves programmed to a partial level, and I didn't even need to do it. And, then it would be very self-directed. And whenever they would do that, then they wouldn't always feel like we were making them come to treatment, with the mandatory 2.5 hours of therapy, that are required in initial, in Pennsylvania drug and alcohol NTPs, that they didn't have to feel like they were dragged into that. that they would be able to pick more, but they could pick and choose. We also had like on-site prenatal classes that made it much helpful to them, so that we could talk about prenatal things, but in the context of methadone treatment, and that the women who were farther along in their pregnancy, or maybe further along in treatment, who'd enter early in their pregnancy, would be able to kind of help support the women who were maybe coming in later or were just new to the program. And they could see that it could work, and I think that peer support wound up being a tremendous aspect, but there were still like informational things that the other women still needed to know, and that we would schedule that out. We have to be able to address things like PTSD, post-traumatic stress disorder, in both OB and alcohol and other drug treatment care. If there was one comorbidity, I think that I would see more than any other, it was that. A lot of anxiety, a lot of flashbacks, a lot of depression, a lot of guilt, a lot of self-blame, so much of that, and not knowing how to deal with issues of touch related to OB care, related to the intimacy of gynecological care, and not even understanding that. And women would talk about that, an example being one woman who was actually had been seeing a dentist for scripts and participated in it, but the payback was that she had to have sex with him, and the sex was in the chair. And so she couldn't go for dental care, and she couldn't go to OB appointments. Anytime she got in, a reclining kind of professional position, she would really freak, so she avoided it, and, therefore delayed care. But helping her to verbalize that, helping her to understand that, helping with that, she was finally able to get through that and get the care that she needed. And being able to communicate this to the OB providers, in explaining what she was going to have done ahead of time. And, she was working with midwives, and the midwives were very calming and very supportive of her. And, the one midwife would actually support her while the other one would be doing the exam, and it made it much easier for her, would help her do breathing. There were just so many other things that were involved in that. The parenting classes, addressing positive parenting skills. Women would always say, well, what's the biggest thing that impacts what the kids do and the outcomes of the kids? And one of the things in one of our long-term studies was not necessarily the withdrawal of the babies. That had an important piece of that in the nursery, but over time the biggest factor was whether the parents could recognize the cues that the children were giving them, and the interactional types of things. That could the parents meet the kids' needs, and were they able to recognize when a child was in distress, and how to cope with that. And many times, as I said, if women were not in settings that grown up in homes that were supportive and nurturing, and then they would not necessarily know those skills. And so they would do the same things and not really wanting to do them, but they wouldn't know what else to do. And either they would medicate to avoid it, or many times then, put skills in place that weren't, appropriate. And we really had to talk them through and learn about those a little bit more. So parenting classes were more than a child does this at what time, but also this is your parenting skill related to that, and to bolster that, and to help that, and to role play, and to learn how to deal with the stress of that, which was, oftentimes an issue. And then women's recovery support, empowerment, and self-management, that they can make decisions and that they can learn how to support themselves. They can maybe think about vocational issues, and they can still do these things while they're on methadone, and learn that when and if they're ready to come off of methadone, that can happen. Oftentimes, whenever they delivered, they found that, they would feel high, and they didn't like that feeling because, as Dr. McNicholas said, that body mass and metabolism decrease, and so oftentimes the dose is a little bit too high, and that they would start thinking about plans to decrease and come down after delivery, and that they could do it slowly, that they wouldn't have to do it very rapidly and in big hunks of milligrams. That we used liquid methadone, and so it was very easy to titrate to 1 milligram levels, and that was great. And we would have some women that would say, this is what I want, and negotiate with us, and that they would sign for decreases that they wanted periodically, and that they wanted them kind of blindly. They would just learn not to kind of look at what their doses were, and ask to have their dose covered on their sign-out sheet. And so they really could participate in that and know as much as they wanted or as little as they wanted about that process, and help empower them to get to where their goals are in their strategies. Let's see. Other strategies are allow to self-directive choices within the boundaries of safe care. And I think that's important. I mean, women would ask us, well, will you decrease me while I'm pregnant? And certainly we couldn't advise that. And it was something that, we don't do that. And I don't know places that do. So therefore, you would need to search around, and, if you can come up with that, we will certainly arrange for a transition for you. But we would not be able to do that because it wouldn't be safe. But if there were women that, wanted to try decreases after delivery, or that there would be choices around that, we really wanted them to do that. Or if people wanted to stay on methadone. I've worked in the field long enough that we had the great cap at 80 milligrams in the state of Pennsylvania. And, people went, I want to stay 20 milligrams and below. Again, those aren't safe choices. Sometimes you have to go above. Sometimes you have to, be on a level, whatever that is. There's no magic in the numbers. That it is very much a fluid kind of thing based upon each individual. But we would have to say these are the boundaries that we have in terms of safe care. What do you want to do, and help negotiate with that? We would really stress positive outcomes given appropriate interventions, that if you do this, then these are the things. Sometimes women would not want the babies to stay in the hospital, and they'd want to take methadone home to detox the babies with, because then their parents wouldn't know that they were drug dependent, or their partner wouldn't know. And, recovery basis for the program was on honesty, openness, and willingness. So we'd ask them, how does that play part in this? And really try to talk with them. And, we would get them to understand we're not going to, that wouldn't be our advisement. And not using methadone. Methadone in babies is very hard to titrate their dose, and actually prolongs the withdrawal. So that question related to 3 months of a baby staying in the hospital may be related on the fact that interventions were kind of not orderly and not following, very well-established protocols that would be able to improve and address those outcomes. But we would really talk with them about that. What's the positive amount? So you let them know that you're doing something recommended, evidence-based, practical for yourself, and instead you're doing something that could be seen as like impulsive and not quite honest. How does that fit, with where you've come so far, in your treatment? And often, of course, logic will prevail in those situations. And, maybe there's some negotiation. You don't have to have the nurses going over the scoring in front of the parents. That's a breach of confidentiality. You wouldn't have the scoring sheets laying directly out. There's some, kind of ways around that, but certainly not that you would avoid doing those kinds of things. Addressing guilt and shame in a positive, supportive ways. folks are just terribly ashamed that they've gotten themselves in this boat. And, particularly, young people that are a little bit more educated, have not come from, like, say, addicted families, have been fairly successful, and there's so much shame and so much guilt. And so, therefore, there's a lot of impulsivity around that. They don't want people to know. They want to get in and get out really quick. And that we have to be supportive of some of those things, but also supportive of, you didn't mean for this to happen. You are responsible for the recovery, but not the addiction. And what can we do to make you more responsible in recovery to be manageable? Engaging partners in support of others in treatment, and sometimes that's a real dual-edged sword. That is very, people that we see as supportive and who those might be are not always the people that we think they are, but also sometimes the ones who we feel are the least supportive, such as abusive partners with their own addictions. Engaging them in treatment can kind of get them, number one, to stabilize their addiction so that they can recognize how controlling they are, and engaging them in their own treatment can help stabilize this family and help them work through some things. A lot more education, particularly with their therapists about why we're doing what we're doing, rather than it just being the woman out there on her own. I've had a lot of guys that were going to come in and tell me a thing or two, but after they got into there and asked me all the questions, I'd say, okay, this is your time. Ask me the questions. I'll explain everything to you. And, they would exhaust them, and then they go, oh, any more? Well, have we convinced you yet of why we're doing what we're doing? Because I know you want the best for your child and for your partner, and I know your partner does that, so I think we all have the same goals, don't we? Yeah, okay, and then move on, And, the old adage, quite frankly, of having your friends close and enemies closer, does also apply here if there is any sense of an abusive situation. It can give you a sense of exactly how critical that situation is and be able to see a little bit more what's happening. And in treating the entire family, we're addressing the family issues for the recovery. We have to address them all the way down the road. And we have to do this not only when they're in the opiate addiction treatment, but also in the hospital for, induction, if they're going in the hospital or in the setting for that, but also in the treatment setting, as well as at the time of delivery and down the road. That at different phases, different things are going to become more central and will pop up, and so it's really important that you address the whole family issues. What happens if mom's still in the hospital and after delivery and the baby is still there and dad comes in high? What happens if the whole family comes in and there's a big party going on in the room? And, I always love those calls, and I would say, what would you do for anybody else that was being disruptive in the hospital? You'd ask them to leave, right? Well, we didn't know if we could ask them to. Sure, you follow what you normally would do in those situations, but we have to address it in the basis of recovery. How does this impact that? We have to assure the compliance with the maternal OB care and OB treatment. OBs have to make sure that they're maintaining in drug and alcohol treatment, as well as the drug and alcohol treatment, ensuring that they're going for OB care. So that means some talking. That means those releases have to be in place. There's not an assumption that if the woman says that she is going to OB care, that she actually is the amount and frequency that her OB provider will want her there. Sometimes there's reason because of maybe a low situating placenta, or attachment issues of the placenta, that they may want to see her more often, or certain issues that may come up that she's not going to be going to regular OB appointments. And I've had people tell me real stories, except that when I went to OB clinic, happened to be visiting OB clinic the day that they were there for their appointment, they happened to not have showed up. and they told me a great story about how they went and what their appointment was, and I go, and that was your appointment yesterday because I was there and you weren't. You know, they have to know that there's not going to be some checks and balances. And I worked in a program where that was, you know, kind of expected of me and my physician. Not all centers have that, but there's an adaptation of that that certainly can be in place, I think, with, you know, some of the outreach efforts that most places have, like with Healthy Beginnings Plus or other initiatives. Utilizing the community resources is really important. Things like early intervention, public health nurses for visits after delivery, and if need be, if there's a high-risk pregnancy, sometimes the visiting nurses will actually see the women prior to delivery. And some proactive health plans like Gateway, for which I work, we have that without an authorization, we will send and authorize visiting nurses for 2 appointments after delivery, after the baby gets home, just to ensure that there's weight gain and there's not, you know, any situations that, you know, would require more intervention going on. But in other situations, again, there's might not be the specific ones, but there's ways to piece this puzzle together so that the services are in place. Other community resources, such as early intervention for these kids, are so important, but making sure that the families are actually utilizing them. Oftentimes the doctors at the hospital, the pediatricians discharging the babies will make the referral, but if there's no follow-up in terms of their parents, then there won't be the connection. It is important to know those kinds of things, and even if for drug and alcohol treatment, to know that level of what other care is available is so important. And it means really working with the other disciplines in order to get this into play, because folks are going to be seeing a lot of people, and that means a little bit more coordination of care. Oftentimes in narcotic treatment, you know, it's one-on-one or, you know, some educational kinds of groups, but, you know, it means a different level of involvement. It means getting personal and a little bit more in their business and a little bit more, you know, into what's going on. And yet I've seen in some places where judges can get into that level of business. Well, if judges and other people can get involved, I think we as treatment professionals certainly should be comfortable enough in there, since we're mostly from the human services field. We have to know our responsibilities as mandated reporters, and this is always a really, you know, touchy kind of situation. And there are people that still don't know what the regulations are around that in their states. You know, in Pennsylvania, just because a baby is born positive does not mean that they have to be mandated. There was a follow-up MA bulletin to the initial regulation around that that did give consideration to women that are taking prescriptive opiates, including buprenorphine, as well as are enrolled in a narcotic treatment program, that there is not mandated reporting if that baby shows up positive, because they should show up positive. And it's how we manage that is really going to be the key to the outcome in terms of the child. And so we have to make sure that we do understand that, and in some areas that still is not very clear about that. And so, and again, I'm addressing Pennsylvania at that point, not some of the surrounding states. In terms of assessing and treating the newborn, the gold standard is the Finnegan scoring system. You know, it was developed in the 70s, and it is still very true today. The signs of narcotic withdrawal have not changed. The baby still manifests the same things, just as in the adults. The opioid withdrawal scales have not changed, because the symptoms are the symptoms. It is what it is. There is a variety of withdrawal protocols. Dr. McNicholas mentioned the management using morphine, and again, that is the standard which we go by. There are some other protocols, but they're not nearly as effective, way more complicated, and they prolong the withdrawal. For numbers of years, we've utilized the morphine or tincture of opium, which is all we had at that point. Now we've gone to liquid morphine sulfate, and we were able to reduce it down to 10 days to 2 weeks is the average. there were outliers, particularly if mothers were abusing other drugs, and particularly Xanax and the anti-anxiety drugs, as well as some, antidepressants, as well as, alcohol or other drugs of abuse. There would be, a lot of mixed kind of effects. The only reason we would use phenobarbital is if we had, a history of, sedative use, barbiturate use or sedative abuse, and we were more afraid of seizures, and babies would wind up withdrawing from the methadone, beginning to opiate withdrawal, but then they would kind of start looking bad a little bit, and we would have to add a phenobarbital for a little bit and then decrease off of that. And that was particularly in those situations, but still, was well accomplished within a 2 to 3 week period of time. And the Finnegan scoring system is available for that, and actually, cited in my reference at the end of the presentation. Looking at the signs of withdrawal and helping to supportively manage it, and if necessary, then medicating as needed. There are some babies that will show signs of withdrawal, but it's very minimal, and in the scoring, it, they can be supportive by, say, reducing the external stimulation of lights and sound, whenever you're working with them, not talking with them, and diverting gaze a little bit, and different things like that we would teach the mothers to help minimize, even if they were in medicated withdrawal, the symptoms of withdrawal, and just comfort the child a little bit. And what it got them is to see that there were things that the mother could do that would calm their babies, and their babies would respond in a positive way. And so we would highlight that. Look at how your baby responds to you. Look, when you do that, see what they did? They really are responding to you. And so it got them to understand very positive and very nurturing, supportive care. And it helped nurture the mothers as well. And so they would want to replicate that in their babies. And they would be so great to be able to see, like, look, when I do this, look at how my baby calms down. And they'd be so proud to show other mothers and maybe the more experienced mothers and things like that. And they would eventually become some of our greatest peer advocates to then the other new people coming in. And so it's a building process with that, and they would take that role on. But being able to see that type of supportive management would be very helpful. And all of those things would be things that would help decrease the amount of time that the kids needed to stay in the hospital. That management in the NICU and hospital setting, that's like a whole different field for people that work in opiate addiction treatment to understand NICUs and how they work. And NICU people have no idea of what we do on the other end. And we really have to meet together and really help to bridge that gap with that. And most of the folks are willing because, again, we have the common goal, and that's improving the outcomes. So if we're able to do that, that's so important. We are able to come together and agree what piece we play in that and how we can reinforce that all together. Again, NICU is oftentimes the place where you have clinicians that really have a sense, because they see how uncomfortable the kids are if they're not in medicated withdrawal, and see how uncomfortable they become, and become very, very angry at the parents. And it's really important for them to understand that. And again, they might be able to treat the babies, but they might not be the best ones to interact with the families or do the education at that time. You have to monitor for problems, and particularly that's as the baby's born. And part of it is, as I said, drug use. There's been lots of times that, again, moms would stay fairly stable, but the fathers would still be using, and, moms would set up the cravings because it was just the people, places, and things. Again, getting back to the addiction treatment and relapse prevention, that we really had to work around that and watch for that. Moms also wanting to get off too quickly. And some of that getting off, as I said, maybe decreasing the dose because they feeling a little bit high or a little bit intoxicated, and that's setting them off a little bit in terms of their craving. But also at the same time, it may be you know, just trying to get off really quick and like a flight into wellness. I'm okay now and everything's going to be okay, when it's not. And also the secrets. In addiction treatment, we always say secrets keep us sick, and it does as well at this time. Hiding the withdrawal from people in their life is really a key factor, and sometimes really working around those is a real challenge. And this is when we really have to add the pediatrician into the coordination of care team, you know, that we can't avoid talking to them. And, you know, sometimes we have to say, are they taking the kids back for their care? You know, what is this kid's withdrawal like? Talking to the hospital, talking to the pediatrician in the community. Adequate discharge criteria from the hospital, and this is from the SAMHSA tip series, and for anyone who's not familiar with that, this is a great series in treating pregnant addicted women as well as improving treatment for drug-exposed infants. Those are the two, you know, gold standards. They came from a lot of years of evidence-based practice, a lot of input from very committed people and very experienced people with the discharge criteria for leaving the hospital. The babies have to have adequate oral feeds and a satisfactory weight gain, have to be physiologically stable, neurobehavioral recovery of the infant, all necessary assessments are completed, and the mother and family is ready and able to safely care for the child. And those are supported by the American Academy of Pediatrics. So on a NICU end, these things have to be in place. So if a child is still withdrawing and not medically stable, they shouldn't be leaving the hospital with medications for withdrawal. And that's why we don't support that, that action. There are clinicians that will still do that. There are some settings people do that. They feel that in the more rural kind of settings that it's not practical to keep the kids, but at the same time it does not meet discharge criteria, either on the drug and alcohol treatment recommendation end or the AAP end. Discharge planning, when can the babies go home? You know, we have to integrate that mother and family into the treatment team. If we don't see those folks in for treatment, that child's not ready to go home yet. We have to establish and maintain the communication with other providers, and from the NICU end, methadone or buprenorphine providers, early intervention, the visiting nurses, if need be, child protective services, any pediatric care, any school programs, any community and support programs, any program available that regard to treatment plans for the child, the mother, and the family. Have to be followed through. Many of our women that are teenage mothers, and yes, teens can be on methadone during pregnancy. That's one of the exceptions, and they may be involved in a school program. Making sure that we coordinate with them so that we know what their treatment plan is going to be and how this, in fact, what their plan is for that. Confirming follow-up appointments and any activities, making sure that we provide written instructions to them, because they're listening but everything is swimming around, and they really need to have reinforcement of this and having written instructions that they can take back sometimes to their program. And one of the things, I'd say, show me your discharge papers. Show me the baby's discharge papers, okay, you know, so that they would go through them and we would review them and make sure that they knew how. And then that way we knew that they had them and that they weren't just kind of letting us know that the baby was discharged when maybe they weren't as in the good shape as what they thought they were. Monitor the status of follow-up plans developed with them, and keep a documentation. Lots of times people from each area that they treat, you know, we'll follow them up for a period of time, but we won't continue to monitor and continue to document. We may ask about it, and I think it's really important to include this in documentation, and it becomes fodder for further study on long-term outcomes of kids. And one of the reasons why there's not a lot of long-term outcome studies is that the kids are lost to follow-up because it's not continued in one setting. For long-term perinatal addiction programs similar to the one I was involved with, it winds up, you know, doing a long-term follow-up. I mean, you know, you're able to see that. But other settings not? And so, are we going to see the same reliability in other settings? We don't always know. Where if we're able to get some further documentation, we might be able to kind of get this information a little bit better out and see what happens. What happens when they're in, not an integrated program and you're patchworking the services together? What does that look like? And are they still following through? Can they still talk about the pediatric care for the kids and understanding that the kids will need ongoing care? Are they immunizing their kids? Are they, taking their kids for dental and vision checks, which are part of the benefits that they may have? Do they have health insurance for their kids? Do they know that they can get health insurance for their kids? What are the, is the family intact? What kind of things are happening with that? And what are the outcomes? And just being able to monitor that. Reducing the barriers to treatment is so important, whether it's transportation, is it child care? We were fortunate to have an on-site child care that was therapeutic, so we not only were able to play and hold with babies, but we were also able to do developmental assessments and look at the outcomes and look at the development of the kids and take a look at what works and what doesn't, not so much. Look at attitudes and behaviors of folks over time. Do people feel better if the mother about the mother being on methadone if there's a good outcome in the kids? Well, certainly, but maybe that will be the thing that will help them reduce their anger or their, frustration with this population. And seeing some successes. Over the years, people said, how can you work with this population, for so long? And don't you ever get tired of not seeing success? And I think it's how you measure success, that you're able to measure that based upon, did I give them everything that I could possibly give them in order to improve that outcome, and did I do everything that I needed to make that happen? One level of success. But if you see a healthy kid, when you see kids playing together that can interact, that are sensitive to other children's needs, parents that are sensitive to their kids' needs, able to go from, no, I don't want on methadone, to, okay, I'm going to stay on methadone, and I am so glad I did this. Those are successes. The success isn't always, for after leaving the program, did they detox off within a 2-year period of time, and, did they have 12 months of sustained recovery after delivery? Those kinds of things are harder to measure. You have to measure the successes, I think, all along the way, and that way you can really see that treatment does work. And also the various resources. Sometimes there's a lot of community resources out there. We would actually go out to some of the neighborhoods in our city and go to some of the housing plans and find out, well, what kind of grassroots kind of housing and other types of resources were available. Who had clothing banks? Who had beyond WIC, food programs? Who did work with the other kids? Were there places where people could go to do like a mom's program? Could any of those help with some of our monitoring? Did they think that we were always the CYF folks coming out? Did they think that we were going to bust them? We were really able to see in the community-based areas what kinds of things worked for that community and how we could link with them. And oftentimes we've had women become like mentors and those kind of, and had, maybe children that had been lost to addiction become, mentors and talk about, their struggles with the women and help them along, help cope, help them gain their empowerment, like with jobs or schooling or other kinds of things. Helping them with parenting and just child care. Who watches them whenever they go to OB appointments? Who, do you have to take, 3 kids under the age of 5 on a bus, and then get a transfer with it, and meanwhile you're 7 months pregnant, your feet are swollen, and you can't stand it? Are there ways that people can help you? Yeah, there might be funding for the bus, but that doesn't help you with all the other stuff. Yeah, sometimes people can help you with that. and develop those kinds of relationships with the community. That kind of consortium level is so important. The importance of a medical home, and for people in drug and alcohol treatment, I'm not sure if you're familiar with the term of medical home. A medical home is a term utilized in the pediatric field in terms of having a place where, just like your PCP, your adult PCP would be, but a pediatrician is a medical home, and this is a place that kind of has your records and knows you, and you kind of feel comfortable with. Well, kids need a medical home too, and sometimes that is at a family practice. Sometimes it's with nurse practitioners. Sometimes it's with pediatricians. But it should be a concept where this person kind of knows all the subspecialists you see. Like if a kid does have, like, say, a hearing problem, they would know the ear, nose, and throat doctor. If they had developmental issues, they would know that doctor. If they had any kinds of, say, anomalies, then they would deal with that doctor. But all the care gets centered in that area and becomes the conduit for that information and helps do care coordination on a pediatric level. And they become very sensitive to this, that maternal drug use is a leading cause for entry in the child welfare system. And the average length of time that a child is in foster care is over 30 months if they go into foster care. And in 2009, the rate of Pennsylvania children in foster care is 10.5. And babies born to mothers actively involved in treatment programs are less likely to be placed. So pediatricians really like women to be in drug and alcohol treatment. If they're going to have anything involved and have an addiction, they would rather than be in treatment and not. And so they're very willing to help cooperate and to foster that, situation, and anything that's involved with positive parenting. They're really not as likely just to get them into child welfare because they know that the kids don't do as well in foster care as if they do in the home. To summarize, the components of a sound perinatal addiction treatment center is one that care is accessible, it's family-centered, it's very comprehensive. You just don't deal with one end, you deal with it all. It's coordinated. It's compassionate. It's culturally diverse. It is along a continuum, and it's competent. In terms of planning and development, and I know that this is always a challenge, and I don't think we do these seminars just for information only. I think we have a task of further planning and development, and even if we have very sound treatment protocols and programs in place, we still need to plan to do a little bit better and develop further the care for pregnant, addicted women and their children. We need to continually improve these outcomes and push that envelope to get better. And in order to do that, I think that anybody who wants and is asking those questions is so important because we're really planning on doing something with it and developing further strategies for ourselves. So, I applaud everybody out there who's interested in this and who's been asking the questions because it means that then we're also looking at the next level, which is planning. And, I usually start with obtain feedback from key stakeholders. With the institution that you're at and in the community about what they feel problems are related to this and to address the issues facing the families and caregivers. That sometimes means even asking the people that have the addiction. Oftentimes people would come and ask me, well, what do you think about this idea? And I said, give me a couple days to chew on it. And I'd ask the women, hey, if we were thinking about doing this, what would you think? Or, somebody said this, what would you think about that? And get their opinion. It is valuable, and it is important, and it's insightful. Oftentimes those folks that you're seeing are going to tell you exactly what they need. They don't know how to get it all the time, but they do know what they need. And also, like people from the various ends. If you're in a methadone treatment center, what do the people that work in drug-free treatment have to say about this? If you're in an NTP and you're not doing IOP, what do the IOP people feel about maybe somebody well-maintained on that methadone joining their group? Or what does it mean if you're going to an OB provider? What does your OBs think about that? I worked with one hospital where the nursery staff, the pediatric staff, the NICU people were wonderful. That I could not get the OB department to budge at all. You know, and it was always a challenge. You know, and the only thing that would work is whenever I said, well, you know, you do have one of my patients, and you will be seeing them, and you know, this is, you know, I'm here if you need me. And, you know, it kind of had to come across that I'm sending you the release of information over. If you want to talk to me, you know, you can do it. And I can tell you some things. Can we work together? And we'd have to go back and forth with this. But in order to, the care was there, and it was the woman's desire, and so therefore it had to happen. And, you know, we had to break some administrative barriers down at times. But that's part of what we do. We suit up, put our helmets on, and forge ahead. We document these efforts, you know, being able to keep, you know, well, we've been doing this, and these are the things, and this is the amount of time it takes. This is the amount of effort, and identify that. Look, you know, we've been doing this, and you know, I've had women that if we were logical, we would not have had a program, because we happened to have a woman who got pregnant on methadone, and we were asking them, as Dr. McNicholas said, and that was our first patient, many years ago. And she happened to get pregnant on methadone, and we said, now what do we do? Gee, we hadn't had this happen before. And if we were logical, because we called all the hospitals, and they all said they never saw an opiate addict. If we were logical, we would have thought we had the only one, until we started looking around, and we actually found Dr. Finnegan's program at Thomas Jefferson University, which is still there today, which the mother study came out of, that Dr. Carol Kaltenbach did, that was alluded to in Dr. McNicholas's presentation. We were able to model after that. We were able to go out, but it took a lot of time. It took a lot of groundwork, but that's the effort that to treat this, improve the outcomes, really takes. That kind of information, it's really great to spend time on versus spending time on redeveloping protocols or using protocols that aren't evidence-based and aren't of sound practice. You can find out. You'll see how much information that you can get. I was able to ask women and able to find out that, you know, over 50% of my women talked about having miscarriages when they self-detoxed instead of getting on methadone with a previous pregnancy, because they found out that they were pregnant and they just decided to quit using or went into detox before they did tox screens on a mission, and therefore they would always, 50% would have had a history of a miscarriage. I'd ask the women, well, did you go to OB care? Because the misconception was women aren't going to OB care. No, they went to OB care. It's just that, did you tell them about your drug use? No. Why? They didn't ask. Okay. Well, why did you tell me? Because you asked me. And I knew if you asked me that you must wanted to know the answer. You wouldn't have asked me if you weren't sincere. I don't know how you measure sincerity, but that was one measure that a woman gave me once. And I would hear time and time again after that. If I asked women, well, have you been to OB care? Yes, I've been to OB care. Well, have you gone back for your appointments? Yes, but not at the same place. That they would go to an emergency room, or they would go to different places, but they wouldn't continuously go there. Well, how come? Because I thought if I told them I was a drug addict and I went back again, then they would report me, or they would arrest me, or, any variations of ideas that they had about what would happen. And so having that kind of information is the building block for then, strategies to how it could work, in each of your areas and communities. continue to discuss those issues to support the positive outcomes in these families and babies. Don't give up on them. They are not expendable. This is not an expendable population. I had one doctor tell me one time when I called him about a woman that was looked like she was beginning to have some cramping and spontaneously abort, and he said, well, we wouldn't see her anyway because, you know, it's just as well. And, you know, those kind of attitudes still exist, and we still have to address those and, you know, address them pretty specifically at times. We have to utilize our best practices to treat the babies during the course of the hospital stay, and as well it applies to the mothers as well. And we have to engage the parents in treatment planning and strategizing. If they don't have the buy-in, you know, then it's going to be us doing it to them, and it will have some outcome. Will be improved. The mothers will do okay, the babies will do okay, but certainly the longer range is not going to necessarily work. We'll only get short-term compliance. And the biggest thing is become a champion of this. If someone had ever told me that 30-some years later I would be still working with pregnant addicted women, I would have said, you're crazy. I fell in love with the population, and there's just so many facets and so much joy, you know, that you can see in those successes, and to understand the impact that each of us play in that. It is so important. And, you know, becoming a champion is just one of the best things because it does improve the outcome for the future of our children. The importance of care coordination, you know, we've talked about that they have to be linked, and that the information can be shared freely as long as we have the collaboration with the confidentiality regulations in place. We have to have those boundaries, but there's ways to do that. And all caregivers facilitate that coordination of the care of the kids. And then the outcome is looking at a child like this that can integrate, that can learn space and shapes and colors and be happy and in an environment that he can be well cared for. And after delivery and after down the road, we as a field want to be able to continue to monitor the trends related to alcohol and other drug use in the various areas and in the field of perinatal addiction, and collaborate with interdisciplinary teams using culturally competent interventions, gathering those resources and addressing the needs, having good follow-up at intervals to look at the outcomes, being positive with our parenting skills and teaching materials on how to care for the infants and children, and consider the development of community outreach programs. And people always say, well, this always takes money, it takes time. Yeah, it does, but this is where partnering with, say, universities, community colleges, using volunteers, students to support that family recovery in every way possible. People oftentimes are looking for opportunities on how to volunteer that could keep data or could keep records or could make phone calls or, you know, can do outreach. And, you know, with a little detective work, sometimes you can really find folks even after they get out of treatment. Know the laws of your state about reporting parental substance use, and know the confidentiality regulations, and establish quality-related actions. Each program has to have certain quality improvement projects, and this is one that's great if you're part of a larger institution to do, because they're always doing quality initiatives, and you know that many times establishing that to really take a look on how these activities are accomplished and what the standard is around that. And then the last one is a practice slide, and this is a challenge slide for those champions out there. And this is a practice slide that in the hopes that you will commit to identifying and contacting just one of the drug and alcohol treatment centers, or if you're a drug and alcohol treatment center, an obstetrician or a clinic or a NICU or something in your area that you're not familiar with, in order to just know what is there, and to, even if you get real brave, to conduct a meeting, a joint meeting between inviting obstetricians in your area, pediatricians, and, you know, good luck with getting OBs and peds to talk to each other, but at the same time, you'd never be surprised what will happen. Social work, nursing, you know, drug and alcohol counselors, with child protective services, any maternity and early intervention initiatives, maternity programs like visiting nurses, maternal child health networks, Healthy Beginnings Plus, any schools that deal with teen pregnancy. Many of them have a counselor or a teen pregnancy initiative. Any community programs, or any other resources to discuss the issues related to maternal substance use in your area, and just talk about what do you see the issues being. You know, what can we do? People get scary, but even, you know, police officials or attorney generals, medical societies, nurse practitioners, there's a lot of people involved and concerned about this, and, you know, you'll be able to get a pack of resources together for the women that you treat and your families, as well as for you to use that helps your interventions with them. And the goal is to have a healthy family and to be able to, you know, have an intact family, a healthy baby, and overall improve the outcomes over time with these kids. And I'd like to leave it open now if there's any questions.
Hi, everybody. I'm unmuted now, so I can repeat everything I just said when my phone was off. We've got a lot of questions here and about half an hour to get through them. Anything that's not answered by 5 o'clock, I will send to the presenters and ask them to just make little notes for their answers, and then I will forward that to everybody. So here's the next questions. Let's see. Would you recommend a pregnant woman who has been taking pain meds as prescribed by a doctor to detox off the low amount or go on methadone? Which would be safer? Anybody?
Are we both on at this point?
Yes.
Laura, are you there?
Yes, I'm here.
We recommend methadone. An opiate is an opiate regardless of what type or the manner that a mother is taking it. But if there is a physiological tolerance and it's during pregnancy, particularly in the first or third trimester, we would definitely recommend methadone or treatment with an opiate.
I would agree, and I like the caveats that you just put on that, Jen, and that is that if there is tolerance and dependence, if somebody, that's physiologic, not talking about addiction, but physiologic tolerance and dependence. I mean, if somebody takes an occasional Percocet or something, and there's no tolerance and dependence, then my recommendation would be that the person not continue to use, period. But if it's regular daily use, even as prescribed, they need to be maintained on opiates.
Okay. What are the maternal effects of opioids in the first months and last months of pregnancy?
Well, one thing that we know is that there are not any obvious teratogenic effects of the opiates.
Right.
In other words, you don't get like increased cleft palate or something like this. Whether or not there are more subtle signs in the first trimester is really still open to study and discussion. One thing that we know happens is the baby does not gain weight. Low birth weight is a universally observed issue with particularly women who are not in treatment. Certainly, we have no evidence that maintained on an opiate appropriately, such as methadone or buprenorphine, we have no evidence whatsoever that the baby is being harmed, other than the fact that they will be born with the possibility, if not probability, of having NAS. But there's no teratogenesis or other issues related to that. Jen, do you have anything to add?
Well, I would only add that the problem comes in the withdrawal from the opiates.
Exactly.
You know, it's not the opiate itself. Opiates have been given for medical reasons for women in pregnancy, years, probably close to a century. And it's just not documented as having, any kinds of effects. But the problem comes is when that physical dependence comes up, and then you need more, to get the same effect, and you would have withdrawal without it. And it's the withdrawal that causes the problems, right. Not that. If you remember Dr. McNicholas' slide, and you remember there's like peaks and troughs, and you just remember that going up and down and up and down, that's not the stability you want. You want that nice gentle glide in that range, and so that's what you want, where if you're going through withdrawal and you're taking pain meds every 4 to 6 hours, you figure you're going to have to do that around the clock if you get dependent. And you'll need more as time goes on, and so you're getting these really high roller coasters. That's what we want to avoid. And so if somebody's occasionally taking an opiate and they're not physically addicted, it's really not going to cause that kind of effect.
Okay. Bottom line, which do you recommend, methadone or bupe?
Wow. Unanswerable question at the present time. We have more experience with methadone. Mm-hmm. The recently completed mother study indicated that both are effective, safe, and appropriate for pregnancy. Mm-hmm. I have heard some people say that if mom is already not on methadone, they would probably use bupe, but I don't think we have the data to address that at the present time.
Right. Okay. And I did want to add, now remember, we're just talking about physical stability.
Exactly.
That's the point. Coming from a methadone treatment program background, and I may be biased with this, but the regulations that people in methadone have to follow and the amount that methadone treatment providers have to follow versus a clinician that's ordering buprenorphine in terms of offering treatment to women is much greater in a methadone program, and I find that you have a lot more resources and support available to you than a clinician out in, ordering buprenorphine in an office. Buprenorphine is, the studies in terms of detox and in terms of maintenance are very promising, and especially even during pregnancy, they're very promising, and in the babies. However, what you miss is that other whole piece of the therapeutic support for this family, that unless you're in a very specific setting using buprenorphine, that would be missed.
And I will say, I completely agree with you, Jen. And mm-hmm. in the mother study,
yes,
moms being maintained on methadone and on buprenorphine had all of the services available yep. in the methadone program mm-hmm. with them. And actually, they had more yes. because they had a contingency program. If they made their OB appointments, they could earn coupons and that sort of thing. So they actually had more. But when you look at the effects of the medication alone, not the effects of treatment in total, mm-hmm. the two medications are apparently about equal.
Okay. Next question. If the methadone patient refuses to acquire or verify prenatal care during pregnancy, what should the MMTP do to ensure a positive outcome?
You continue to work with them to get them to understand why that would be helpful. And offer, like, could we make an appointment from my phone? Could you call from my phone for an appointment? Or could I meet you there? Or what would stop you from doing that? You know, you work with
my question is, why not?
You know, why wouldn't you want to do that? What's the barrier? And then you work around the barrier. You're trying to identify what that is. And really, you know, really looking at it. And then just, I mean, I'd have people that, you know, would be, and I'd say, well, we could call from here. And, you know, it'd be like, oh, okay. You know, how many people are going to turn you down? You know, or run out of your office. Not too many, you know. But you work with it and find out what is it behind there. If somebody's doing that, you know there's a reason. And you're just looking at what's the motivator. What's the motivator?
Okay. What would you recommend for a patient who is taking clonazepam and Adderall unauthorized regularly and becomes pregnant, i.e., would discontinuing use actually be harmful to the baby?
I would say supervised detox while maintained on methadone in a hospital.
Second.
You know, they can stay. That's how we manage the women that use other kinds of drugs that you can anticipate that there may be withdrawal, and particularly, like say, intrauterine seizures and desats in the baby, desaturations in the oxygen level, and you know, a lot of other complications, and actually prompt a preterm delivery or abruption with the placenta. We would do that in a supervised setting, and we would do it in the hospital while maintaining them on methadone and adjusting their methadone dose as appropriate.
Okay. Now I have one that's a multiple-part question. Would you ever consider converting a methadone patient to buprenorphine? And if so, which trimester? That's the first part of it.
During pregnancy? No.
No.
Okay. Please comment on the recent AJOG article entitled Methadone and Perinatal Outcomes, a retrospective cohort study where methadone exposure is associated with an increased risk of adverse perinatal outcomes.
I'm not familiar with the study, so I can't comment on it.
Second, but one of us will look it up.
Yep. Yep, that's right. And I mean, partly, you know, again, you have to really look at the confounding factors. If we haven't heard yet, this is not a simple issue. This is very complex. And people who get in methadone treatment don't get there from using occasionally. They have addiction, and their lives are unmanageable, and there's so many factors that are going on with that I don't know that you can completely rule that out. Some of it may depend upon how the women were treated with methadone. Some of it may be what they meant by adverse perinatal outcomes. Some of it, you know, I mean, we just really have to take a look at a lot of different factors related to that outcome, rather than look at one particular situation. And I'm eager to look at that article.
Maybe the person can email or message back with the issue number.
Mm-hmm.
Okay. Do methadone withdrawal symptoms differ from buprenorphine withdrawal symptoms in the neonates?
Inherently, no. The issue is that certainly in adults, the withdrawal symptoms with buprenorphine have been more mild than with methadone. However, opiate withdrawal symptoms, signs and symptoms are pretty much universal across opiates.
Mm-hmm.
So you may have more or less intensity of a specific symptom, but no, they do not differ in the neonate or the adult.
And they may take a minute longer to occur, a little bit longer to occur because of the prolonged half-life. If you take a look at half-life of, say, a short-acting opiate versus a long-acting opiate versus a very long-acting opiate, it may take a little while to exhibit itself. But, I totally concur with Dr. McNicholas based upon the mother study findings. There's no difference.
Okay. This next is also a multi-part series of questions, so I'll just do one section at a time. What percentage of children born from methadone mothers end up having behavioral problems, such as ADHD, autism, or learning disabilities?
We don't know. There's not a lot of good long-term studies. There's several being done. But again, follow-up has been an issue from that perspective with the mothers. And again, the confounding factors. If you could pull out just that variable, that would be great. But you can't pull out that one variable. And even though programs have been very long-standing, I don't know that we've been able to kind of see those kids for that length of time and be able to weed those things out. And again, so many of them are lost to follow-up. I can give you a lot of anecdote, but I'm not going to be able to give you statistics.
I completely agree, Jen, and I think that one of the things that we have to remember when we're looking at confounding variables in this is not only the opiate dependence in the mother and the stability of the family, but other dependencies, nicotine ingestion, whether or not mom's been using cocaine or sedative hypnotics, whether or not dad has been, what are the genetics. The confounding variables on a question like that are just mind-boggling, which is probably why the study's not really been done in a way that answers the question.
Because you can't pull those variables out. Maternal stress factors, medical conditions, environmental conditions. How do you control for those things? You can't. I mean, one of the largest studies that I knew of is the CEDAR study, which is a retrospective study looking at children, particularly boys, of parents who, one parent, mostly fathers, may have had alcoholism or other, I believe, alcoholism. And, it was so hard to tell what factors, and you're drawing serotonin levels and neurotransmitter levels and showing pictures and seeing what can do the response. I mean, they get to be very costly and very long-term studies, and can they be conclusive? I don't know that you can.
Jan, I'm going to ask you a question because I think I know the answer, but I'm not going to speak for you.
Okay.
Ideally, I would like to say that no woman during pregnancy would have to be treated with methadone or buprenorphine. However, if I have a woman who is opiate dependent and is pregnant, the worst thing that I can do for both that woman and her baby is to allow the dependence to continue.
Yes.
Unabated.
No
Is
doubt.
methadone ideal? Or is buprenorphine ideal? No. But addiction is worse.
Exactly. And, and we all see the consequences of addiction. Jails, institutions, and death. Let's go back to 101. We know that will happen. And is that, those of us who work in the addictions field, those aren't acceptable outcomes. So we have to try something else.
Okay. This is going back to a topic that was covered regarding dose reduction after giving birth. I'm very concerned for my patient that I have described previously, currently at a methadone dose of 210 milligrams and exhibiting anxiety and reporting a diagnosis of bipolar disorder post-delivery. I have assured the patient that we will work closely with the staff psychiatrist regarding her mental health diagnoses. However, the speaker discussed decreasing the dose. Is it by clinic direction or by patient report?
It's mandated by patient.
It's individualized for the patient's care.
Yeah. And you cannot decrease the dosage without the patient's knowledge and awareness. That's a regulation, a methadone regulation. They have to be aware, and they have to buy in, and they have to be given alternatives if they don't want to do that. We can't just go ahead and do it. But it should be their choice. And, you know, obviously this person has a lot of perceived or reported or suspected behavioral health issues that are going on, and perhaps stabilization. You got to figure out what you're going to do first. Do you really need to worry about decreasing the dose, or do you want to stabilize the behavioral health issues? I go with stabilizing the behavioral health, then worry about dose adjustments if it's not impairing her functioning. Lots of times after delivery, right after delivery, you know, women are coming in somnolent. They're talking about being zonked. They're talking about being high. They're talking about getting cravings because they, you know, they remember this is how they felt and they hadn't had it in a while and they don't want to feel like that anymore. That's one thing. And they're falling asleep, and they're afraid they're going to fall asleep with the baby, you know, holding the baby. They're not going to hear them, you know, because, you know, they feel that their dose is making them so sedated. That's very different than, you know, somebody voluntarily wanting to decrease after delivery.
Well, it's also very different than the specific case that this person is talking about, and that is why dose adjustments need to be individualized.
Exactly.
Okay.
Not everybody's going to come off of methadone successfully.
Most of them aren't.
Exactly. You know, and, you know, over the years in working with the women, it's interesting because I found about, you know, there was a population of women that kind of wanted to come in, have their baby, and eventually get off, and they did so within a, you know, a period of time, and it probably took them almost 5 years to do that. You know, and you know, they might have had you know, some, you know, they documented change in multiple efforts over a period of time, and the time is somewhere around 7 years for anything, any habit to change. Well, imagine this with addiction. And then you have another population of women who come in and they don't quite know what they want to do. You know, they're not as, they just really don't know. They're just lost, and maybe they have comorbidities, and they're still debating about what their end goal is. And that's okay. And then you have another population who comes in and says, I don't know if I even want treatment. I don't even know if I want stabilization. And their treatment is usually a wreck, you know. But that's pretty much the same with most populations of anybody you see, because when I started to mention this to other people, they kind of scratched their heads and said, yeah, you know, you get them coming from all different angles, and you really have to meet them where they are.
Okay. How can we support mothers in parenting and caring for their child, as well as bonding, when most of the babies are temporarily placed outside the family after birth?
Good question.
Yeah. That would be a good question for the folks who facilitate the placement.
Yeah, because I know at the Jefferson Clinic, most of them are not placed outside the family.
Right, and nor were mine. And we worked to make that happen. We would encourage in the hospital, like I said, women could go in and they could visit with their kids, and they had an open door policy. The kids didn't go to rooming in, but the mothers could go in so that we knew what was occurring, and we could see their bonding, and we could see that, and they weren't placed. And I think that's understanding the child protective laws, and do we really have to do that? Again, I've gotten a lot of misconception about what the law is, and so sometimes are we over-reporting? And when we over-report, then are we being overzealous? One of the biggest things that we did is we invited the juvenile justice judges, the ones who saw family court that dealt with child protective custody, into our treatment program and said, this is what we do. How can we work at this?
Well, and the other thing is you may need to work with your local resources to get a a housing situation where mom and baby can, where mom can stay with any other children she has, if necessary, during the pregnancy, and then return there that is structured and helpful.
After delivery.
After delivery. And so that you don't have the separation.
Right.
Okay. I'm trying to scroll down through some of these others. What if a mother is on prescribed benzodiazepines? Do they affect the baby?
Yes.
Yes, they do. And my question would be, who is prescribing? Is it the methadone provider or a psychiatrist working closely with that person, or somebody outside of the treatment modalities and the...
Or illicit.
Yeah, or illicit. I mean, sometimes people just go to anybody who writes a script, and yes, they've got a prescription, but is it appropriate? And so I would look into that.
Please address the impact of mother's nicotine has on opiate NAS. Did you understand that? Okay.
Again, that's one of those factors that you can't always identify out because there's not a lot of studies of just babies exposed to nicotine. There's a lot more studies about babies that are exposed to drugs. And so it's hard to pick out what part is just the nicotine versus what part is the other withdrawal. I mean, we know that there is a nicotine withdrawal. It's been documented. So it can only, you know.
I completely agree with you, Jan. The issue is it certainly doesn't make NAS any easier.
Yeah. But there's no other particular treatment that you do for it. There would be no further interventions with that.
Swaddling and comforting. And
yeah. The comfort measures, the reduction of stimulation, because it's mostly a neurobehavioral irritability that they're going to experience. And, you know, it will happen for a period of time. And certainly any of those calming measures that the mother can put in place is going to be helpful to calm the child. Yeah.
Okay. Now we only have a couple minutes left. Somebody did ask about screens, and I figured that I can get some suggestions of those from you offline, and then I will send them on to everybody next week.
Okay.
There's a question here. Oh, and then the article that was cited earlier, the person did reply with the article information. I will send that out to everybody as well. Are dosage adjustments for pregnant patients affected by type of opioid, such as heroin versus OxyContin?
No.
No.
Okay.
The dose adjustment is based on what that patient needs at that point in time, not what they were on.
Okay, and I guess this will be the last one. My patient is in the early phase of pregnancy, expressing feeling strong withdrawals until the point that this is hard to read. My patient is in the early phase of pregnancy, expresses feeling strong withdrawals until the point that they wake up feeling sick. We split the dosage in the morning and half in the afternoon. She reported feeling better. However, she continues thinking of using heroin. I'm giving her cognitive therapy. What else can I do to help her?
Well, so far it sounds like you've been doing everything right. My only question would be, is her dose adequate, period?
I agree.
Do you need to go up maybe 5 milligrams on each dose or something like that? Is it primarily psychological or is it physiological? And the other thing that she needs to take into account, and I think this is one of the things that Jan was talking about, is there's a lot of changes with pregnancy. And is one of the things that we have to remember is our patients frequently relate any and all discomfort to withdrawal. And we need to educate them on that, as well as craving. Anything that causes psychological discomfort can be related to craving, and we need to educate them on that. And it sounds like you're doing everything right. As I say, the only thing that I would look at is her overall dose and whether or not that needs to go up a little bit.
I had one mother that used to come in, and she was pregnant, early in pregnancy, and she would come in saying, I don't really feel well. and one of the newer nurses just assumed that it was, you know, that. And I said, well, how long has this been happening? And she said, since I got pregnant. And it was like, duh, you know, and I mean, years of experience and, you know, things like that. It's like, well, yeah, it's morning sickness, and there's sometimes nasal congestion, which then will cause runny nose in pregnant women, and they think that that's it, or maybe they have seasonal allergies, or maybe, you know, it's just so many things that you really have to separate out. But, you know, when you've ruled those other things out, then sometimes dose adjustment, and depending upon where they are, because sometimes if mothers have been very, very heavy in their use, and they've been using fairly regularly a lot, and they start to stabilize, what happens is, you know, I've had women that could come in 4 or 5 months pregnant and aren't even showing. They get stable on methadone, and all of a sudden they pop. You know, and they got bellies, and you can see them just grow. You know, the kids just take off inside of them, and that may be one of those same things that's happening. Is that, you know, maybe, you know, she's starting to grow a little bit. Maybe she's gaining weight. Maybe she was very gaunt, and, you know, now she's, you know, she's starting to improve in health-wise. That might need a little bit more of that dose to, you know. So that it extends over that little bit more body mass and the amount of metabolism she's having from that baby starting to take off and grow. And that needs to be weeded out too. I mean, you know, you don't want to be, I don't know, you don't want to give methadone away, but certainly you want to give it appropriately. And sometimes it's a dose adjustment that's the answer. And everything seems like they're going right, and they're doing a great assessment, so just digging it a little bit further.
Yep.
Okay, well, I think we're just about to hit the 5 o'clock mark, so thank you both very much for this. I think
You're welcome.
Been very interesting, and we've had a large attendance, and I'm sure they all appreciate your answering their questions. So at this time, I'm going to end the webinar, and thank you again.
Thank you.